afternoon. Well, good morning. Sorry, good afternoon. We're already thinking about the afternoon. Good morning and welcome everybody to the Woo You Cozy Pharma weekend. What a perfect weekend to do this if you're in the Northeast. I don't think I'd be doing anything else but sitting here doing some CE. So if you're in the Northeast, it's definitely a cozy weekend to do some CE. So just a reminder, we have a jam-packed weekend of some amazing Woo You speakers. So welcome everybody. First off is Dr. Tracy Offerdahl, Treatment of Pain, Opioid Choices and Issues for Patient and Practitioner. We're very happy to have you back again once more on this Woo You weekend, Dr. Offerdahl.
Thank you.
I'm your host, Dr. Jennifer Stewart. And some reminders for CE certificate, please fill out the survey. The link will be posted in the chat and emailed to you after the event concludes. Attendees must be online for a minimum of 50 minutes per hour of credit. Just a reminder, this is a 2-hour presentation, as are all the CE this weekend. CE certificates will be delivered via email and sent to ARBO with your OE tracker number. Please allow up to 4 weeks for your certificates to be emailed. A QR code will be displayed at the end of the event that you can scan with the OE Tracker app. So if you haven't joined us yet this year, the layout looks a little bit different. We've got some great new software, but your Q&A and handouts can still be found. They're on the right-hand side of the page. To minimize, use the down arrow. To open, use the chat button. So a reminder, we will have time for Q&A at the end. So put those questions in there throughout the presentation. I know it's a long time to remember your questions, so we will make sure to spend quite a bit of time at the end. It is my great pleasure, I think, to fifth or sixth time to once again welcome Dr. Tracy Offerdahl to Woo You. She's a pharmacist and a pharmacology and therapeutics professor for over 30 years. She's currently on faculty at the Pennsylvania College of Optometry at Drexel University, where she's the course director and instructor for the pharmacology courses. She's a practicing clinical pharmacist and a fellow in the American Academy of Optometry. So with that, I'm going to turn it over to you, and I'll be here at the end.
Thank you. Appreciate that. Good morning, everybody. Guess we're getting towards lunchtime here on the East Coast, but not quite yet. So we're going to talk about some opioids, but before I do that, I'll just mention here that I have nothing to disclose. Any potential financial relationships have been mitigated. And the only thing that's not really relevant, I guess, but I have a non-salaried affiliation agreement with New Skin Pharmanex. So I love to do this lecture. I've done it so many times because the beauty of this topic, and there are other topics where you can do this, but it's sort of telling a story, really from a pure pharmacology perspective and a pharmacist perspective, and how this is relevant to you as optometrists for your patients. And, you all may know somebody, or, directly, or maybe, through somebody else that maybe has opioid use disorder. And then we're also going to integrate very importantly, some ways that you can think through the process of potentially utilizing these medications in your practice. But as a subject, it's so important to kind of hit the highlights in terms of the drugs, but also some tools that we have available as practitioners for potential opioid use issues, or how we can protect ourselves and our patients. So real quick, I wanted to go through 4 major types of pain, because at the end of this, I'll go through, usually, very quickly, but other options that certainly you are aware of as optometrists and, optometric physicians. You're aware of other options outside of opioids for sure. Many of you probably have your DEA licenses. So, you may have had the opportunity to write a prescription for one or more of these medications, and we'll go through some of the pluses and minuses there, just as a reminder. So nociceptive pain, that's what we're going to talk about really here today. It's typically the result of tissue injury. It is normal processing of pain. You cut your finger off, what remains hurts, right? You have a scratched cornea. I mean, there's some nerve endings there, but, it's an appropriate location. You have a abrasion on a cornea, it hurts. And then we have inflammatory pain and abnormal inflammation caused by inappropriate response by the body's immune system. That is handled differently, or should be handled differently many times than traditional nociceptive pain. And oh, by the way, our opioids really are most appropriate for the nociceptive pain. They certainly work some for inflammatory pain, but it can be kind of a sledgehammer to kill a fruit fly type scenario, which we don't want to do. Neuropathic pain, pain caused by nerve irritation, damage, etc. And it can also be described, neuropathic pain, as inappropriate processing of pain. Because you can have nerve damage in one place that actually is exerting pain elsewhere in the body because of how the nervous system, runs throughout the body. And then functional pain is pain that occurs without a clear structural or disease cause, maybe a communication error. It can kind of be a combination of the three above in terms of type of pain or how it's being shown in your body. But fibromyalgia is a good example of that. That could also fit under maybe neuropathic pain as well. Irritable bowel syndrome, visceral pain, which is just organ pain. An example of that is renal colic. So we're going to focus mostly on nociceptive pain with a little bit of information regarding the neuropathic pain. And that's kind of what we have here. I said most of what I wanted to say. So in terms of options, we have certainly our opioids. We have our over-the-counter meds as well. But for neuropathic pain, I just wanted to mention some of the highlighted most common medications that we use for neuropathic pain and sometimes functional pain. So our adjuvants, adjuvant just meaning, add-on medications. So that's what we have here, multi-purpose and specific to types of pain, depending upon which one we're using. So, we use a lot of anti-seizure medications for sure, and that's what we have outlined here. So certainly you're familiar with, I'm sure, gabapentin, brand name Neurontin. That is not a controlled substance federally. But I think like 8 states now, maybe 9, actually have decided to make gabapentin, Neurontin a Schedule 5 controlled substance, mostly in southeastern or, eastern, southeastern states, West Virginia, Mississippi, et cetera, have made this drug and a controlled substance at the state level. And the reason for that is people can abuse gabapentin in high enough dose. You can get high from it, or high, I'm using air quotes around the word high because, these are CNS depressants like opioids. The other reason why some states have decided to make gabapentin, Neurontin a controlled substance is because people use it so they don't go through withdrawal until they can get their next hit of a CNS depressant like benzodiazepines or opioids, et cetera. Pregabalin, Lyrica brand name, on the other hand, it sounds like gabapentin, right? Gabapentin, pregabalin, it's just a nod to their mechanism of action. These are GABA system inhibitors. So they're making an inhibitory system, which is our gamma aminobutyric acid system. That's an inhibitory system in our central nervous system. These drugs, including pregabalin, gabapentin, make an inhibitory system more inhibitory. So they're slowing down a system that already is slowing things down. Pregabalin, Lyrica, is a Schedule 5 controlled substance in every state in the nation. And then we have topiramate, Topamax as another example. Just keep in mind, because what I want to build here in terms of part of the story in my humongously long prologue that I have here, I just want you to understand that you're going to have patients that are coming and sitting across from you in that chair that you are examining, that are here maybe just for their, yearly or twice yearly comprehensive eye exam. And you're going to look at this patient's intake information and see a list of medications that is quite long, maybe 1 or 2 opioids plus an antidepressant, maybe an additional drug that is used as an anxiolytic, something for sleep, something as a muscle relaxer, et cetera. You're going to be faced with patients that have chronic pain that are sitting in the chair looking at you, and now you're trying to decide whether or not you can use a medication. Topically, it's not as much of an issue, but if you are trying to decide whether or not you can use another systemic medication, an oral medication, for some reason in their care, and they're on all these medications. So we have to sort of build this picture of what do you do in an acute pain scenario, options there, but what do you also potentially do in someone who's on a litany of medications, and you've seen them, even if it's not for pain. People have stuff for heart failure, hypertension, diabetes, the ramifications of longstanding poorly controlled diabetes, et cetera. You get chronic pain on top of it, and it makes the situation that much more difficult. Goals of pain do differ. So you're going to be looking at, from a treatment perspective, acute pain. That's what you're going to be dealing with as practitioners for the most part in terms of what you'll treat. So acute pain is you want to manage the level of pain as much as possible while still trying to avoid adverse drug reactions. Some you can't avoid. But it's going to be for a short period of time. Acute pain management tends to be for a short period of time. When does it switch from acute pain to chronic pain? What is the well-respected definition of how do you get from acute pain to chronic pain? Usually if somebody has a pain problem that is still going on at 3.5, 4 weeks, some people will move it to 6 weeks. So it's kind of a, sliding scale definition there, but, more than a month, up to 6 weeks, whatever. If it is no longer acute in the sense that it just isn't going away and patients are still being evaluated, we do kind of categorically move a patient from an acute pain management treatment plan to a chronic pain treatment plan. And that's because it's looking like for some period of time, maybe forever, hopefully not, this patient will have a pain issue that is going to have to be managed chronically. The goals are different. With chronic pain, we still want to manage the pain, but our goal usually isn't to get it down to a 0. If we can do that with a reasonable treatment plan, including opioids many times, okay, that's great. But that isn't our goal. We say to these patients, of which I have been one, if you've ever heard me talk on this subject, I was a chronic pain, I still am. I have a spinal cord stimulator. I just don't take any medication. But, I remember being told, we're going to manage your pain. We're not going to get you to a 0. That's not our goal. Our goal is to get it low enough where you can mother your daughters, you can, work, you can do all the things you love to do. And that's a hard thing to wrap your brain around when you're the patient sitting there in pain. It's subjective, right? Everybody, if you just stop and think about how do you assess pain? I know with my 2 daughters when they were younger, they're young women now. But, one of them, my youngest, tough, high pain threshold. She would have no expression on her face. She could have severed a finger and she would have said, I believe I need a Band-Aid. And she just had it was personality and very high pain threshold. My older daughter is much more demonstrative with everything. And I call her my rainbows and unicorns girl, very like, her friends call her extra, I guess. And she is somebody that is also very tough. But, if she had some sort of injury, she would be much more likely to be freaking out about the injury. So same parents, they were raised the same way. It is a subjective issue. So how can we add an objective component? And the importance of this is in the slide where it says, pain assessments and scales help guide therapy into one of 3 categories. So we want to get to the point where if you have a patient sitting across from you or just daily life type stuff, where does this patient's pain fit? Is it a 1 or a 2 or a 3 on the pain scale? Because this guides treatment. And it might even be just home care treatment, forget the opioids, trying to decide if somebody should go to the emergency room. But, if somebody's a 1 to 3 on the pain scale here, you can see that a 1 to 3 is considered mild pain. Whereas moderate pain is a 4 to 6, and then severe pain is, I say, 7 to 10. This particular scale says 7 to 9. That guides treatment. If you're mild pain, you might be able to take 1 ibuprofen, and that's going to be good enough for a mild pain scenario. You get more into moderate pain at a 4 to a 6. A 4 is going to be different than a 6, even though they're both considered moderate pain. And you're going to see that with our treatment choices as well. And then same thing when you look at severe pain, a 7 is still bad. And, you can't really sit still. You're going to be moving around a lot. You can't really concentrate, with a 7. But a 7 is still a lot different than a 10 on the pain scale. The beauty of these pain scales, and there are several combined here. It's just one I found several years ago, kind of Googled combination pain scales. And this is one I found that I liked. This has the number scale, right? 0 being no pain and 10 being the worst pain you could ever have or possibly imagine. We have the Wong-Baker facial grimace scale, which is, maybe not quite as, I hate to say accurate, but I guess I'm okay with saying maybe it's not quite as accurate. But what if you have a child, or what if you have somebody who, has English as their second language and there are some communication issues for whatever reason? Then the Wong-Baker facial grimace scale, which is a statistically valid pain scale, can be used. We've got the color scale here. And then I think one of the most important parts are the descriptors here at the bottom, because I always tell the quick story. Back when I was, I think a resident, I was probably a resident. I went in to talk to a patient and try to assess, their pain scale. And I said to this patient, 0 being none and 10 being the worst pain you could ever imagine or you've ever experienced. That's how I described it. And so the patient said, oh, my pain is a 10. And I was thinking to myself, I'm looking at you and I'm pretty sure your pain isn't a 10. But the more I just chatted with her, I realized it was my fault, because I had said in my description, 10, the worst pain you've ever experienced or the worst pain you could ever imagine. That was true of her scenario. I don't remember exactly what the problem was or, what the injury was, but that was a 10 for her. And then I said, well, let's look at some of these descriptors. It wasn't this exact graphic, but 7 to 9 or 10, it says the pain is quite intense and is causing you to avoid or limit physical activity, cannot concentrate on anything except the pain. In the end, this patient was assessed at having maybe a 5 or a 6, because she, was having trouble concentrating, was fidgety, but, could still concentrate some. All that being said, it's important to, really show patients the different categories and how to describe them. Okay, so treatment options. We've got our non-opioids, we've got our opioids, and we've got our adjuvants. Our non-opioids are acetaminophen and our non-steroidals. We've got our opioids, that's what we're going to concentrate on here. And then our adjuvants, which are just our add-on medications. All right, our opioids. Sorry, I had pneumonia a month ago, and I still get a little tickle sometimes. Okay. Our opioids, otherwise known as narcotics, and now that we have hydrocodone in the list, with our other opioids, and I'll show you kind of an updated list of these. It's an appropriate use of the word narcotics. Mainstay of therapy for the treatment of pain. Look at the second bullet, no maximum dosage limitation. That's crazy when you think about it. I mean, when have you ever seen a drug where there's a statement next to it that says no maximum daily dose limitation? That is true of opioids. And when you think about it, if you've ever seen a show like Intervention, or you've ever seen somebody or known somebody that is a drug abuser, that is one of the most terrifying and remarkable things pharmacologically about opioids. No maximum daily dosage limitation, it's tolerance. That's what's allowing this to occur. So you look at what somebody who is a drug abuser, opioids like that, uses heroin. Probably you could look at that person and say, if we took 1/20th of the amount of heroin that this person is using and give it to somebody who doesn't abuse opioids at all, it would kill the person that doesn't use opioids at 1/20th of the dose, or even in some cases, 1/100th of the dose when we look at fentanyl. Receptors become tolerant to the effects of the opioids, which probably everybody on here listening does know. So if you look at the FDA labeling, the package insert that comes with opioids, our Vicodin, our Tylenol with codeine, our tramadol, our morphine, all of these, certainly there's going to be a maximum daily dose listed there. But I'm saying pharmacologically that isn't correct, or it's not true. Useful for acute and chronic pain, they mimic the actions of endogenous opioid compounds. The endogenous opioid compounds include the enkephalins, dynorphins, and endorphins. So you probably heard of at least the endorphins part, or maybe all of it, if you think back to like neuro discussions in optometry school. But enkephalins, dynorphins, and endorphins. This is one of the things I love about medicinal chemistry, biochemistry, pharmacology, because think of the very, very, very smart people who came up with a drug that plugs into these receptors. They figured that out, starting in mice usually, or even, fish before mice in many cases. And they were like, you know what? I found a chemical that's going to plug into what the cavemen had to use as receptors and their internal chemicals. Because before we had drugs, This is what we relied on for pain control: enkephalins, dynorphins, and endorphins. When that's not enough, and this plays into that pain threshold to some extent, maybe some of us have more enkephalins, dynorphins, endorphins. Maybe for some of us, like my younger daughter, who's got a very, very high pain threshold, maybe she just has better endorphin, dynorphin affinity in her receptors, in her opioid receptors, or maybe she's just got more receptors. We don't really know. But when that's not enough, and our body, is in that fight or flight, but it's not enough to control pain, or when the panic emergency situation starts to wear off, the adrenaline starts to retreat, then that's when the pain really shows itself. These are some of the drugs that we're looking at here. So I wanted to update our Schedule 1, just as a basic definition. Schedule 1, these are drugs that are not considered to be medically necessary. Now, you probably know, medical marijuana, or marijuana, we'll say marijuana, THC, was punted to the states. I don't even remember, probably close to 10 years ago, right? It went from federal oversight of THC to state control. But the federal government still had marijuana, THC, listed as a Schedule 1 controlled substance. As of, I guess it's probably been a year and a half now. A year and a half. It wasn't this past summer, the summer before. The feds said, you know what? We're taking THC off of our Schedule 1 controlled substance list. And, it's still a state issue. So that's why THC, wasn't allowed in airports, even though airports aren't necessarily federally owned, or there's federal involvement in them. So guns and THC, don't bring them to the airport. I'm not suggesting you should bring them to the airport now. I'm just saying things have changed to some extent. So if you look at Schedule 1, what else do we have? Marijuana has been taken off. Heroin, ecstasy, 3,4-methylene dioxymethamphetamine. That's that MDMA, if you've ever heard of that, otherwise known as Molly. We've got peyote, lysergic acid, diethylamide. That's that LSD. Psilocybin, which is the magic mushrooms, etc. So there's a little bit of play in terms of oversight. There are some states, southwestern states, where peyote can be used, and even maybe psilocybin in some cases, where there are indigenous populations that use it in religious ceremonies. So that changes a little depending upon where you are, but generally considered to be research only. Schedule 2, this is what I was saying about the term narcotic. Narcotic is an accurate description now because of our movement of hydrocodone from Schedule 3 to Schedule 2. So now if you look at the list just quickly here, morphine, fentanyl, meperidine, hydromorphone, oxycodone, methadone, hydrocodone was moved. And you guys know that more than many practitioners, simply because it went from, you can write it as a Schedule 3, and then all of a sudden, that was threatened. But thankfully, many of you as optometrists and many of your friends, et cetera, really advocated for keeping hydrocodone on the list of things you can prescribe. So now, depending upon where you are, and if you have a DEA license, most optometrists have the ability to write for hydrocodone. So you've got a Schedule 2. When you go down to Schedule 3, combination products with, it's usually acetaminophen and codeine. So you have a Schedule 3, and you have a Schedule 4 here with tramadol, Ultram. So it's nice. You've got a Schedule 2, a Schedule 3, a Schedule 4. And from an acute treatment of pain perspective, even if it's just for, a day or 2 or 3, you have one for severe pain. That would be your hydrocodone, right? You've got one for, more mild pain or moderate pain, I guess, the codeine, and same with tramadol. Personally, I am a tramadol fan more than a codeine fan, even though tramadol is a Schedule 4 and codeine's a Schedule 3. I think tramadol's a superior drug for treatment of pain. We'll talk a little bit about why here as we move through the slides. Okay, we cannot escape drug receptor complexes. I'm just keeping an eye on the time here. That's how things work. So mechanistically, we're reminded that these are drugs that are mimicking the actions of our internal, how we were made, endorphins, dynorphins, and enkephalins. So now we have substances, and we've had them for, several thousand years, that mimic these substances. Relieve pain and induce euphoria by binding to opioid receptors. The opioid receptors that we're concerned with here are mu, kappa, and delta in the brain and in the spinal cord. So oversimplifying it, but good enough for a Saturday morning. So mu receptors, kappa receptors, delta receptors. They have a little bit of crossover for sure, but they're also, have many individual characteristics that make them unique, particularly the mu and kappa receptors. The most active, I guess that's a good adjective, the most active or the most potent receptor from an analgesic perspective with the opioids would be the mu receptor. When one of these drugs or when one of our endogenous substances, endorphins, dynorphins, and enkephalin, plugs into a mu receptor, we get pain control, analgesia. Most people get euphoria, meiosis, sedation, constipation, respiratory depression, and addiction. Certainly not all of those are good. You're using the medication as a patient for analgesic potential. And, certainly the sedation is a welcomed effect of the drug plugging into the mu receptor, because lots of times when you're post-surgery and you have an opioid, it helps you sleep, which is a wonderful thing. But people become tolerant to the sedative actions associated with this drug, for sure. Even people that are, I'm not talking just opioid use disorder addicts, I'm saying people who have pain and are being appropriately treated with opioids, as you get into week 3, week 4, week 5, week 6 of using opioids, the sedation wears off. And, it very quickly, you do not have any sedation from the opioids, after a few weeks to a month or so. That's one of the reasons why people with chronic pain, even if they're on opioids, drive. That's an entire discussion we could have that would take, 2, 3, 4 hours. So I'm not meaning to trigger that, but just saying that that's one of the reasons it occurs, because the sedation wears off. So we're looking at, a drug plugging into a mu receptor for this discussion because we want the analgesic portion of it, right? Look at this euphoria. It might seem strange, but if you've ever taken an opioid, had your wisdom teeth removed when you were 17, or you've had surgery or whatever, many of you, if you would be willing to admit it, I'll be willing to admit it, felt like a little woohoo on the opioid. It's a function of the receptor. Unfortunately, this euphoria can go all the way from like, oh, I think I feel good, to woohoo, to woo, wow, that was great, or a yeehaw. It's a sliding scale. And it depends upon the patient. It depends upon how often they've taken the opioid first dose and many, many other things. You don't want people that end up with the yeehaw, but you can't stop that. It's just how they're programmed. But I am always very frank when somebody's getting a pain med from a staffing pharmacist perspective. I'll say to somebody, hey, I know you just blew out your ACL, MCL, the orthopedic surgeon's giving you just a few days of oxycodone, just plain oxycodone. Doesn't have to be mixed with acetaminophen like in Percocet, but 5 milligrams of oxycodone gave you enough for a few days. I want you to understand that it's going to give you wonderful pain control. Use it for severe pain. You're going to feel like, oh, I feel good. Like today's a great day. The sun is shining. I think the sun's brighter than it was yesterday. Things like that. Very normal. But you do not want to chase that feeling of euphoria. And then, I'm very descriptive when I'm talking to patients. You don't want to chase that. You should not be taking another dose to get that warm, fuzzy, the sun is brighter than I've ever seen it type feeling. You should only be taking another dose of an opioid because they should be dosed as needed, generally for acute pain. You should only be taking another dose for pain control. So when it starts to wear off and the pain is coming back, don't wait till the pain is severe. That's a hard thing. Hard to chase that. But don't dose to euphoria. It's just a normal response of the receptor after, the endorphins, dynorphins, or a drug plugs into it. Notice respiratory depression. This is what kills somebody on an opioid. So if you see somebody, accidental overdose, it's the respiratory depression. We'll talk a little bit about that. Notice addiction is here too. You can't separate it out. Is there a genetic component? Yeah, there is in some people. But that doesn't mean that it's a 100% chance that somebody's going to become addicted because they have this addiction. Then there are some polymorphisms that make somebody more likely to have an addiction issue. That's just your genetics. But whether or not that action is expressed can be turned on or off. Just because something is in your genes, there are very few scenarios where it's like, well, it's in my genes. There's a 100% chance it's going to happen. That does occur in some things in medicine, but usually not with addiction. Kappa receptors, here we get analgesia, diuresis, sedation, meiosis, dysphoria, psychomimetic effects, probably could have highlighted that too, respiratory depression, constipation. So this is a scenario where if people have maybe more kappa receptors or just a stronger kappa receptor drug complex, these are people that are like, yeah, I don't really feel good on that. It does not make me euphoric. Actually, it makes me feel like I'm a little bit, off my rocker. I had a patient say here a little while back, or I feel anxious or almost like, like I'm psychotic. Generally, these people are, pound for pound, less likely to seek opioids from an abuse perspective because it doesn't make them feel good. They don't like how it makes them feel, but that's a small population of people. And then delta receptor just gives us some analgesia. This is a very much less potent relationship between the drug and delta receptors. Otherwise, we would just have delta receptor agonists because look, you do get other things from delta receptor drugs plugging into them, but it's just not as strong of a drug complex. All right, so just to show you once again that mu receptor is the strongest. I mean, I thought this picture was great, but it's a little small here. Mu receptor, they look like bell peppers, I understand, but this is our mu receptor, this is our kappa receptor, this is our delta receptor. So I just wanted to show you affinity. And these are arbitrary pluses or numbers. So I could have just as easily, found a picture that maybe had like 100 of these little white pluses under the mu receptor, and then maybe had, 40 pluses under the kappa receptor, and then maybe I would have had 8 under the delta receptor because the drugs do plug into the delta receptor. The point of this is just to show you that the affinity is so much less with delta receptors, and then less with kappa and the most with mu receptors. And that's why we have the drugs that we have, because they are mu receptor agonists with less kappa and just a tiny bit of delta receptors. I love this picture. Depending upon what your screen looks like and how this came up, the point is not that you need to be able to read all of this. But I always say, when I'm giving this live or even when I'm giving it virtually, I always throw my hands out for years and I say the beauty and the problem of opioid receptors is that we have them from the top of our head to the bottom of our feet and everywhere in between. We have opioid receptors everywhere. That is a medical marvel and a good thing in the sense that no matter where you have pain, we have, an opioid dose is going to plug into all these receptors and it's going to control your pain. Some better than others. It really does kind of depend upon the scenario. But if anybody's ever had an opioid post-surgery or whatever, it works for most people. But when you think about the bad that has to come with the good, that's drug therapy, right? Or any type of intervention. You always want to try to make sure minimally that the benefit outweighs the risk by 50% and a feather. 50% and a feather more beneficial than the 50% and no feather. And that's the bare minimum. But I mean, if you can have a use of a drug that is exceedingly abundantly much more beneficial than the risk associated with it, that's even better. Not always the case, particularly with opioids. So if you just look at, a couple of these places here, you see these red fuzzy pom-poms here. These are locations, we're just referring to kind of these paragraphs over here, brainstem, spinal cord, brain, and intestines, where we get some of the good and some of the bad as well. But I just wanted to refer you to the fact that we have opioid receptors everywhere, but also over here on the right where it says the brainstem, it gives you a little bit of information regarding how somebody dies on opioids. The brainstem is particularly vulnerable to an overdose. Cardiac and respiratory control centers are found in the brainstem. When receptors are flooded with opioids, breathing and heart rate drop. Some deaths occur within minutes, but most often there is a period of inactivity lasting several hours after opioid intake. And that's the thing. Someone, unless they happen to be with somebody else who has Narcan, this is a painless and a silent death. And it is a CNS mediated brainstem, mediated respiratory depression, and they just never wake up. So it's a scary scenario for sure. All right. So a nod towards formulations. We have two types of opioid formulations. We have immediate release, fast acting, short acting, and we also refer to them in my world, pharmacology and as a pharmacist, but also in pain management scenario, breakthrough meds. And I'll show you what I mean by breakthrough meds. So these are immediate release, short acting, fast acting, breakthrough meds. General uses, acute pain management or breakthrough pain. I'll go back to breakthrough pain here in a second, but just some examples of what do we use for acute pain. Immediate release, short acting agents, Percocet, Tylenol with codeine, Tramadol, Vicodin. So notice I put all three meds that many of you as optometrists with a DEA license can prescribe. There's that Tylenol with codeine, there's that Tramadol, and then Vicodin is hydrocodone and acetaminophen. So your three choices. Then we have controlled release, the synonyms, and I use synonyms in air quotes because if this were a pharmacology lecture to pharmacy students or pharmacists or pharmacologists, I would have to completely change what I'm going to say. But for our purposes, controlled release is a synonym for long acting, is a synonym for sustained release, is a synonym for extended release. To be a purist or, pedantic about those definitions, there can be small differences between all of these, but the whole point is they're long acting. What do we use it for? Basal control of chronic pain. Typically not for acute pain, nor in opioid naive patients. So things like OxyContin, it's oxycodone continuous release, long acting. MS-Contin, that's morphine sulfate continuous release. And then the Duragesic, that's fentanyl, the patch that you may have heard of. So why is this important? Because in an acute pain scenario, you certainly, nor do you have the legal ability to write a prescription for a long-acting opioid. A long-acting opioid gets into the bloodstream and looks kind of like this. It's just a flat line. You don't get a big peak after it's absorbed and then a real quick and sustained drop in blood flow, 3, 4, 5, 6 hours later. Controlled release means it's controlled and it's usually just nice and steady over the course of 8, 12, 24 hours. So if you have somebody with acute pain, they're not going to want a long-acting agent. I mean, if that's their only option, it is what it is, but thankfully it's not. A long-acting controlled release, sustained release, extended release product doesn't give you it's going to start working here in about 20, 30 minutes and I'll be good to go. It's more of like a 45 to 60 to 90 minutes where you then start to feel the pain control. And if somebody has an acute pain issue, that's a long time to wait. So, basic reasons why we don't use the long acting. It can also be dangerous. So let's say somebody is opioid naive. Opioid naive just means, as it implies, that somebody's never had an opioid or it's been a long time. So their receptors really have no tolerance to speak of because it's, I'm 56 now and I got my wisdom teeth out when I was 16, it's almost 40 years, right? If I had never had an opioid between 16 years old and 56 years old or 17, whatever I was, I would be opioid naive because I have no tolerance with my receptors. That's important because a long-acting agent lasts much longer than a short-acting or immediate release agent. And if somebody's going to have a problem with an opioid and it's long-acting, that may be a harder thing to back up or reverse. So for acute pain management, it's our short-acting agents. Now, the only other thing I'm going to mention here this term breakthrough. I mean, it's pretty self-explanatory, but from a treatment perspective, I want to at least show you what it means. So if somebody has chronic pain, and this was me for 2 years when I was, it's probably been 25, 26 years, I was diagnosed with this congenital kidney abnormality that nobody knew existed until I had this problem, this pain, where one of my kidneys was literally kind of having seizures, they described it, where it would cramp. I mean, they finally diagnosed me with renal colic, which just means we have no idea what the heck is going on. But anyhow, it's very painful. I mean, it would start, I would throw up and pass out, and that was it. Bad. So for not quite 2 years, but we'll just say 2 years, I was a chronic pain patient until I went to every specialist trying to figure out what to do. And I was told, there's nothing we can do. You just have to be on opioids and 15 other medications for the rest of your life. So, I was put on, I don't know, I don't even remember anymore, but let's say OxyContin, because it's oxycodone continuous release. That would have been a long-acting agent to give me basal control of this renal colic. And I was lucky because this only happened from about like 3 a.m. in the morning until maybe like lunchtime. So I actually didn't have to have 24-hour pain control, but I needed to have something that was going to last me nice and sustained, like we do with insulin, nighttime insulin, to give you basal control, just nice, even control. So in my case, I only needed that for 12 hours. But what happens if I took my OxyContin, which lasts me for 12 hours? But what happens if like 3 hours in, I started to have that renal colic, that cramping of my kidney, and the OxyContin was not enough? Well, I can't take another OxyContin. 2 long-acting agents, I might not wake up, or, I might quit breathing. So you would always have then a short-acting opioid for breakthrough pain. So a quick on, quick off opioid. It could be anything. It could have been morphine. It could have been tramadol. It could have been Vicodin, Percocet. It didn't have to match the same chemical. You use it for breakthrough pain. So when somebody's taken their medication that's lasting them a sustained amount of time, but yet they had pain on top of it, that's what the immediate release short-acting agents are referring to when I say breakthrough pain. Very appropriately. Thankfully, I found somebody who would implant a spinal cord stimulator. And so now I have electrical impulses that interrupt the pain signals from my kidney when that happens. All right, couple little categories here. Opioid subcategories. We've got our natural opioids. This is significant because from nature, morphine and codeine. Think of the top allergens. Top allergens on your patient's list. They say penicillin allergy, sulfa allergy, codeine allergy, sometimes aspirin allergy, neomycin allergy. What holds all those together? They come from plants. They come from nature. Not everybody has problems with plants, but it's a protein that is different than my protein, my human proteins. And if we have immune systems that are a little, high test all the time, then we are potentially more likely to react, from an immunologic perspective, to a foreign protein rather than a synthetic or semi-synthetic product. So semi-synthetic opioids, oxycodone, hydrocodone, hydromorphone, and then oxymorphone, which we won't talk about. Methadone is completely synthetic. And then other synthetic opioids, fentanyl and tramadol. Heroin is also synthetic, but it is an illicit substance, as you know. So we're going to talk a little bit about allergies. What happens when somebody lists codeine as an allergy? Well, we need to ask them, what happens exactly for that reason. So there are other opioids, and it can kind of show you, I liked this graphic, so it's just in your handout, but just, some of the other verbiage associated with these agents. We've got our opiates, morphine, codeine, and then our semi-synthetics, oxycodone, as we indicated. And then the synthetics are called non-morphinians. Sounds rather like water-dwelling creatures, but it's just referring to, these aren't morphine and they're completely synthetic: fentanyl, methadone, tramadol. So structure matters. You certainly know that with antimicrobials, antibiotics, and it matters just as much here with our opioid type substances. All right. The purpose of this discussion is not just, to entertain the troops, so to speak, but certainly there is an educational component with this opioid crisis that we are squarely, in the middle of, probably the fourth in fairly recent history. And there are a lot of practitioners and scientists and just citizens of the world that blame this on OxyContin that came out in the 90s. And maybe we'll talk a little bit about that. But when it says on this particular slide, I liked this graphic. If you go over here to the right, it says lethal dose comparison. So this is a dime, and you can tell on your screen probably it's, a dime. Heroin, the same amount of lethal dose compared to a dime, 10 to 12 milligrams. That's the amount of heroin that you would need. So, maybe 15% smaller than a dime amount. And then here's fentanyl. Now this is pharmaceutical grade fentanyl, not the illicit crap that is everywhere now. That's much worse. Probably if we were talking about illicit fentanyl as the amount comparison for how much would kill somebody, it would be probably 1/50th of the size of this little 1 to 2 milligram pharmaceutical grade fentanyl. That's how potent it is. It is terrifying. And it's put in everything now from an illicit drug perspective. But when you look at the drugs and those that cause the percentile total deaths in overdose, opioids, that's 68% of overdose cases. And that includes our pharmaceutical grade opioids, and it certainly includes our illicit substances as well. Heroin, illicit fentanyl, et cetera. Cocaine, 20-ish%, psychostimulants, 20%, and then methadone, which is an opioid, synthetic opioid, but 4%. So something to be worried about. Let's go through just a couple of product names because I guess it's probably mostly just a nod towards showing you the difference in products very quickly, but also, electronic prescribing is a wonderful thing and probably most of you use it. But in the case of certain chemicals, certain substances, you might say, like, I want to give my patient morphine, and you type morphine into what drug are you going to use, and you get 85 different choices. This is part of the reason why. All right, morphine, the standard opioid to which all the others are compared. Because, a prototype means maybe it was the first drug, or sometimes if it's not the first drug, it's just the one we use most often. And in the case of morphine, it's really both. So we compare all of our other narcotic substances to morphine in terms of efficacy, potency, and side effects. And generally, you could have said to me, yeah, if you ask me what should we use morphine for, you would say, yeah, probably severe pain, not mild pain, and even moderate pain with morphine might be a little bit of like sledgehammer to a fruit fly. Lots of different brand names, and that's the part that can get a little complicated. So, if you pop it into electronic prescribing, once again, you say morphine sulfate, all of these are morphine sulfate. All of these products would say morphine sulfate, 10 milligrams, 20 milligrams, 80 milligrams, whatever. This is a short-acting agent, MSIR. That's its actual brand name. Not available anymore, but we still call it MSIR. Morphine sulfate immediate release. Morphine sulfate immediate release. And then the three here on the bottom are more long-acting, controlled-acting, extended release products. And this includes MS-Contin, morphine sulfate continuous release. Don't you love it? Back when the brand names made sense and told you something about the product. It's not true anymore necessarily. I mean, I could invent a drug and name it after, my poodle, even though I don't have a poodle. Cadian, also controlled release, and Avenza. But look at the difference between these two. MS-Contin, morphine sulfate continuous release, really the first long-acting product that we had available at all. It lasts 8 to 12 hours. Cadian lasts 12 to 24 hours, and Avenza, 24 hours. There are all morphine sulfate long-acting, and they just have, different lengths of ability to control pain. Here's hydromorphone. You can tell that it's structurally related to morphine based upon its name. Most common brand name is Dilaudid. Certainly, this isn't on your list of drugs that you can prescribe, but you'll see patients on it. It is a very, very potent, second only to fentanyl. It is our most potent opioid pharmaceutically available. So if you go down here, it says very potent is hydromorphone. And this is what we do in my world. When we're trying to change from one opioid to another, we compare them based upon potency. So just for reference, 30 milligrams of oral morphine is equivalent to 8 milligrams of oral hydromorphone. So back when I spent time working with, on pain service, pain practitioner, I would do this sometimes, because if a patient, you know, has been on OxyContin for 2 years and now they come in and they're like, I don't know what happened. The OxyContin worked great, you know, for the past year and a half, but I feel like I have to take more and more of my breakthrough medicine. I feel like it's just not working as well anymore. Lots of times, most of the time, that is not a function of their pain getting worse. Lots of time, it is a function of their receptors, their opioid receptors, becoming tolerant to the OxyContin that they've been using for 2 years. And that's when you would say, okay, we don't want to keep upping the dose. That's a terrible idea. That's how people end up on hundreds of milligrams of oxycodone per day. It still happens in 2026, and it's a disgrace. What we would do generally is say, okay, we're going to completely change your treatment protocol. We're going to switch you from oxycodone, the OxyContin. We're taking you off of that, and we're going to switch you to, it doesn't matter, morphine, long acting. So you would come up with a comparative dose, and this is what we do, these potencies. But let's say we were going to switch them to hydromorphone. Let's say they were taking 30 milligrams of long acting morphine. So we took them from 30 milligrams per day of long-acting morphine, and then we said, okay, it's equivalent to 8 milligrams of hydromorphone. We'd actually lower the dose of the hydromorphone, start them on long-acting that, and, you know, kind of keep the dose as low as possible. Last thing we want to do is keep feeding into tolerance. It's dangerous. It's, you know, almost malpractice in many ways. All right, codeine-based products. Here's codeine, and this is certainly one you can prescribe in most states. Schedule 3. Here's hydrocodone, also one if you have a DEA license. I don't know if it's all states, but probably pretty close for optometrists. Schedule 2, and then we have oxycodone. Just as a point of reference here, codeine is a great cough suppressant. Hydrocodone, also a great cough suppressant. Oxycodone really has no cough suppression to speak of. Interesting, right? They're structurally related, all, you know, related to codeine, or they are codeine, but not all of them give cough suppression. 2026, most pharmacies don't even keep hydrocodone cough syrup on the shelf anymore, because, you know, it's kind of a heavy hitter for a cough anymore. It's a Schedule 2 narcotic, which it wasn't always. Hycotus, it's just one of the brand names of hydrocodone cough syrup. You know, used to be a Schedule, I think it was a Schedule 4 maybe back in the day. But regardless, if you need a codeine-based cough suppressant, all pharmacies carry the codeine product. And that's what most places won't even order the hydrocodone cough syrup for anybody anymore. Codeine pound for pound is a pretty weak analgesic comparatively. And if you just remember the 30 milligrams of morphine is equivalent to 8 milligrams of hydromorphone, look at this. 30 milligrams of oral morphine is equivalent to 200 milligrams of oral codeine. So it's just showing you that it's a much weaker analgesic, which isn't always bad. That's not the problem with codeine. I mean, not everybody needs a potent analgesic. So certainly plenty of people will use a Schedule 3 codeine with acetaminophen. I have Tylenol number 3 bolded here simply because all pharmacies carry it. So if you need a patient to have pain control today and you're going to write for codeine, this is the one you should consider writing for, because every pharmacy will have it. I mean, generally, every pharmacy will have it. Whereas if you look at Tylenol number 2 or Tylenol number 4, where you have less codeine with number 2, more codeine with number 4, pharmacists are going to have to order it. And that sort of defeats the purpose. If, you know, today's Saturday, if I were the staffing pharmacist, I'd say to a patient, oh, I just got a script from your optometrist for Tylenol number 2. I can have it for you Tuesday. That doesn't help much. So we want to write prescriptions for drugs that most pharmacies will carry. Always keep in mind the amount of acetaminophen that patients are taking. And remember that the Food and Drug Administration in somewhere between 2014 and 2017, I just can't remember the exact year, did not mandatorily lower the max daily dose of acetaminophen, particularly in over-the-counter products. But the Food and Drug Administration said, look, we know we have said that max daily dose of Tylenol acetaminophen is 4,000 milligrams per day for 45 years, 50 years. Now we're saying that people still go into liver failure from this drug. So we're going to tell over-the-counter folks to just say, probably stick closer to 3,000 milligrams per day. and not, 4,000 milligrams per day. But if you need to go up to 4,000 milligrams per day for a few days, it's probably fine. But in prescription products, the Food and Drug Administration absolutely lowered the amount of Tylenol in pain combo Tylenol products and opioids at that point. So drugs like Vicodin, et cetera, had to completely reformulate their products. So, don't forget about the amount of Tylenol and tell people not to take additional Tylenol outside of the opioid. What else? OxyContin. So this is oxycodone, but it's controlled release. This was the drug that I mentioned, in the 90s when it first was marketed. And I remember this, talking to drug reps that worked for the pharmaceutical company that made OxyContin. They were going around to practitioner offices and basically saying, there's compared to morphine and hydromorphone and whatnot. I mean, this really doesn't have the abuse potential because it's long acting. So, patients aren't getting that big peak in the bloodstream that gives you the whoopee as much as if you were taking a short acting agent. And while on paper, I can a little bit agree with that. I mean, you won't, here's what I mean by that. If you had a room of people that were addicts, opioid addicts, opioid use disorder folks, however you'd like to refer to that situation, but you have a room full of people that are abusing opioids, and you said, you have a choice. You can either take oxycodone 10 milligrams, short acting, or you can take oxycodone 10 milligrams in OxyContin form. Pardon me. And you gave them a choice. Every single one of them would say, oh, I'll take the short acting. Thank you very much. Same dose, both oxycodone. Every single one of them would say, I'll take the short acting, please, because it gets you a big peak in the bloodstream, more likely to give you that really good feeling of euphoria rather than flat. Same amount of drug, but so that's the problem. And that was part of the marketing. Boy, did they do us dirty. And practitioners, et cetera. And we just didn't know quite as much about, the controlled release formulations and how people would respond. And I mean, we did. We can't use that as an excuse, but I think probably more of what added to the issue of sort of downplaying the significance of oxycodone was the fact that it was, a relatively new chemical. And we weren't really looking at in much great detail the genetic components associated with addiction in some cases, an actual polymorphism that is leading somebody towards addiction. We didn't look at the psychological components that lead people to addiction. And there are many. So anyhow, it was horrible. So OxyContin is still used, but let me tell you what, even as a staffing pharmacist, I staff, every Tuesday for a 14-hour day and then, decent number of weekends. I can't tell you the last time I saw long-acting oxycodone used. Can't tell you the last time. So there's a Netflix documentary I know about the family and whatnot, but here's the issue. This does not dissuade anybody from trying to get high if they can only get their hands on a long-acting oxycodone. So the original formulation, it was a coated tablet, but if somebody wanted to get high, they wouldn't swallow the tablet and say, okay, I know I'm going to feel the drug and get maybe a little high in 45 to 90 minutes. No, they would crush it. And when you crush it into a powder, as indicated in this picture, next slide, and then you mix it with water, while this isn't the greatest of techniques in this particular graphic, but you're able to suck it into a syringe and then inject it anywhere you want to. The older or the newer version, the company has been under so much scrutiny. So maybe 12 years ago, I lose track of time, but maybe a little bit more, 15 years, something like that. The company said, you know what, we're going to reformulate OxyContin. We're going to make it an unadulteratable formulation. Well, where there is an addiction, there is a way. And there is no such thing as unadulteratable, other than taking all the opioids, illicit street drugs to pharmaceutical grade, locking them in a cave, sealing it shut with cement, et cetera. I mean, okay, then maybe they'd be unadulteratable because nobody can get to them. But other than that, there is no such thing as an unadulteratable drug of abuse. But when you crushed it, it didn't go into a powder. So when you crush it, the outside coating is kind of like a sticky glue-like substance. So when you crush it, it just kind of flattens out like that. It doesn't make a powder. So if you add water to that, it creates a kind of a glue that you can't suck into a syringe. So the company was like, thank you very much. Yes, it was all my idea. Aren't we great? But again, where there's an addiction, there's a way. So you just mix this with, a alcohol type substance, and then it goes into a solution that you can suck up into a syringe. Or I know addicts that have said to me that they just suck on the tablet until the glue-like substance on the outside is gone, and then they crush it. So there's no such thing as unadulteratable. And then we have short-acting oxycodone products, still very popular. We've got Percocet, the most common brand name. Some of these that are crossed out here, these are just the strengths with acetaminophen that were available prior to the FDA saying, no, 4 grams per day is not ideal in many scenarios. And the FDA made manufacturers completely change their formulations. Again, don't forget to mention to patients, there's Tylenol in your pain med here that I'm prescribing for you. So be careful with anything you take over the counter. Oxycodone, 20 milligrams is equivalent to 30 milligrams of morphine. So it shows you that oxycodone is a little bit more potent. And I think hydrocodone fits with this one as well. But, the fact of the matter is people have their drugs of choice. People, there are people who are abusing them will say, I prefer oxycodone over morphine. I have patients sometimes say, my practitioner wrote a prescription for morphine for me. I'm not going to take the morphine. That seems like a big drug, and that's scary, which I can appreciate that, from a patient's perspective. But your body doesn't really look at it that way. I mean, morphine does seem like a big deal, but I mean, if you dose it correctly or appropriately or whatever to control pain, morphine is really no more scary than oxycodone or hydrocodone or, hydromorphone. It's just a different drug. So everybody's got their drug of choice. Some people prefer morphine. Some people prefer heroin. Some people prefer oxycodone. Some people prefer fentanyl. Not that you have like a drive-through of drug choices, but people probably do in a lot of places. And then here's our hydrocodone product. You can see, once again, mixed with acetaminophen. Most common brand name is certainly Vicodin, but there are also Norco and Lortab, which are the exact same thing, save for 25 milligrams of acetaminophen. So I encourage you, if you're writing a prescription for hydrocodone plus acetaminophen for your patient, that you just, pick, I usually say the 325. So whatever strength you want of Vicodin 5 milligrams and 325 milligrams of acetaminophen, that is usually readily available. Once in a while, I'll get back order issues or unavailable for manufacturer for the 5/325 Vicodin or Norco. And then you or somebody else will write a prescription for 5/325. And I have to call you and say, listen, we can't get the 5/325 right now, but we have 5/300 sitting on the shelf because it was the only thing we could get. So can you send me a new prescription? Can you believe I need a new prescription for 25 milligrams of acetaminophen? By law, I do need that. So you'd be asked to send a new prescription, electronic. Let's see what else we got here. Let's move on to some opioid allergies so we can get through exactly what we need to get through here. What does it mean if somebody presents as morphine allergic? Well, it means they were exposed to morphine and they reacted, right? Naturally based substance. Does it mean if somebody's allergic to codeine? It's a little bit of a trick question, but fundamentally it might mean that the patient was exposed to codeine and they had an allergic reaction. But here's the thing. Of the opioids, codeine is the most likely of the group to make patients nauseated and or vomit. It's the way it plugs into the BARF center, which is by the brainstem. It's called the chemoreceptor trigger zone. It's where most of our anti-nausea and vomiting medications work, the drugs like Zofran, et cetera, ondansetron. So when a drug like that or a drug like this has a high affinity for those receptors, then if it's not an anti-nausea vomiting medication, if it's a drug like codeine, it's going to cause nausea and vomiting. So the large majority of people who are listed as codeine allergic, if you say to them, hey, I see you have, penicillin listed. What happens when you take penicillin? Hey, I see sulfa. What happens when you take sulfa? You should make a note of that. It's important from a counseling perspective in every medical discipline, healthcare discipline, but also helps you make decisions as practitioners. The large majority of patients, when you say, I see you're allergic to codeine, can you tell me what happens when you take codeine? The vast majority, almost all the patients will say, oh, it makes me so sick to my stomach. Or I had a patient say many years ago, and I loved the term, I'm so barfy on codeine. Fair enough. We're not going to write a prescription for codeine. But, madam or sir, it is not actually an allergy. It's an intolerance. And it's important that I tell you that because you need to get it taken off of your allergy list at the pharmacy, with your primary care, with me, et cetera. That's an important distinction, because if somebody's listed as codeine allergic, whether it's true or not, any drug that you write for as a practitioner or any other practitioner with prescribing privileges for opioids, inpatient, emergency room, surgery, outpatient, whatever, the only drugs that they can take that will not cross-react in the computer algorithm and scream, they might die, they're allergic to codeine. The only choices we have left are fentanyl, methadone, or meperidine. And many of you probably never even heard of meperidine. It's an oldie, Demerol. Fentanyl, methadone, or meperidine. Not great choices for this scenario. And none of those are we really going to use for acute pain management. I mean, other than fentanyl and surgery. So it is imperative that every single person in the healthcare medical team, I don't care what your discipline is, you should ask about allergies and just help guide the patient. If you're uncomfortable saying take that off as an allergy, fine, totally understand that. But you could say, you know what, talk to your primary care, talk to your pharmacist, and just explain, I don't actually have an allergy. I just am intolerant to it because it makes me barf. Because if a patient's ever in a medical emergency, that's a hard thing, or even in a hospice situation where, meds can be delayed and withheld because of codeine allergy or even a morphine allergy that's not actually a true allergy. So thank you for listening to my TED Talk on codeine allergies. So I already said, I get so excited about my content here that I already said fentanyl, methadone, meperidine. We have to just, be part of that, assessing allergies appropriately. I mean, if there's any question, if the patient's like, I don't know, it was when I was 5 and I had my appendix out, but my mom just said I'm allergic to codeine. And now you're sitting there and they're 35 and, there's some reason you want to give them a prescription for an opioid. If it's something sketchy like that, well, I shouldn't say sketchy, but uncertain, where they're like, I don't know what happened. I was 5. Then we err on the side of caution, right? I have to sort through it a little bit differently. I mean, technically you can't take tramadol either. So, all right, miscellaneous, couple little comments here, since I mentioned these, but fentanyl, as an illicit substance as well. The fentanyl that is on the street, the illicit substance, it's coming from all over the place, different countries, being manufactured illegally, is probably the scariest chemical out there for sure. And it can be put in THC products. It can be put in along with, kind of our psychostimulants, what am I thinking? Adderall, things like that people get, that students share, at university when they're studying for exams and they're like, oh my gosh, I need to stay up. I need to do an all-nighter. So their best friend says, hey, I have an Adderall. I have a Ritalin. Do you want one? It won't hurt you. It's just going to make you stay up to study for the exam. And then they don't wake up because it's laced with fentanyl. Black box warning against use in acute pain and in opioid naive patients. That's specifically the fentanyl patch. This is a wonderful drug for people who need it. Chronic pain, malignancy, but also for non-malignant chronic pain. And there are plenty of people who have significant severe pain that's chronic, that isn't malignant. They don't have cancer, but anyhow, it's a patch that goes on the chest wall, stays on for 72 hours. They take it off carefully, get rid of it, and then put a new patch on. So it gives nice, beautiful, sustained, steady state basal blood levels and pain control. Here's meperidine, Demerol. I don't really have much to say about this. We don't use this often, although I will say last time I was in the hospital, for my arm surgery, weirdly, they had methadone or meperidine, rather, Demerol, as my pain pill choice. Thankfully, I didn't take any. I just was using the nonsteroidals and acetaminophen. But I was like, meperidine, really? That's like, 1982 called, and they want their pharmacology back. It's just a tough drug. It's got active metabolites. It can trigger drug-seeking activity. Sometimes people with specific gastroenterologic issues or, sphincter issues in the upper GI tract, sometimes those GI docs will use it for those patients. Typically reserved for morphine or codeine allergic patients, methadone. But if I were able to sit in a room live with you guys, I would say, anybody heard of methadone? I'd see some hands go up, and then I would say, what would you think methadone's used for? And the large majority, if not all of you, would say for drug abusers, for people who are trying to get off opioids. And you would be correct. But it's also a great drug for chronic pain. For the same reason we use it for opioid abuse disorder or opioid use disorder is the same reason that it's good for chronic pain, because it's long acting. It's dosed differently, so I threw this in. You see it in your handout. But basically, you have, two scenarios here. If you have a patient that's only taking methadone and they're using it once per day, this patient is probably in a methadone treatment program. And methadone isn't the only drug. Suboxone is another one, et cetera. But, some people do great on methadone to keep them from using opioids, and other people do better on Suboxone. So one size does not fit all. On the other hand, if you have a patient who comes in and you're looking at their medication list that was inputted, and you see that they're on methadone, and it looks like they take it twice per day, and they're also on another short-acting opioid, because methadone is a pure opioid agonist, just like morphine, just like oxycodone. It just has different kinetics. So if you see somebody who's taking methadone twice per day usually, and maybe the dose is a little higher than what you've seen, and they're also taking a short-acting, immediate release PRN opioid, they're probably using it for pain. You can always ask. And then bringing up the rear here is tramadol. Great drug. Has, different mechanism of action. It is a mu receptor agonist, but it's called dual action because it also inhibits the neuronal reuptake of serotonin and norepinephrine. And if you remember, when you are inhibiting the neuronal reuptake of a neurotransmitter, it means that more is going to hang around to do a job. So we see increase in norepinephrine, we see increase in serotonin, and we get that beautiful mu receptor drug complex. And that's a wonderful thing. So I love this mechanism of action. There are a couple of cautions that I want to mention. But back up here at the top, it says tramadol, brand name Ultram, which you can't even get anymore. This is what you would use as an optometric physician in your patients if you wanted to use tramadol. I should have here, it comes as 50 milligram tablets. It's the only way it comes is 50 milligram tablets. That's the one to use. Some people use it as often as every 4 hours. I mean, even for acute management of pain, I like to say 6 to 8 hours for tramadol, and most people can get that mileage out of there. So, maybe 3 times a day for acute pain management. Tramadol does come mixed with acetaminophen. Don't write for it. It's a great combo. The problem is, as a matter of fact, I went to a talk here a year ago, and the optometrist, there was an optometrist there, great guy who was up there saying, tramadol with acetaminophen, Ultracet, that's my drug of choice as an optometrist for pain. I write this prescription for everybody. Patients love it. It works great. And I had just been on stage basically saying, don't write for tramadol with acetaminophen, just write for plain tramadol. And if you want them to take acetaminophen, tell them to get it over the counter. We were really saying the same thing. It's just our reasons were different. So what I mean by that is the only reason why I say don't write for tramadol with acetaminophen, Ultracet, is because not all pharmacies carry it. So we're in the same scenario as if you would write Tylenol number 4. It's a Saturday, so someone would come in, or you'd send a script electronically for tramadol with acetaminophen, and I'd look at it and I'd be like, oh man, we don't carry that. I can get it maybe for Monday, but it might be Tuesday. Defeats the purpose. So that's, just a word of cautionary tale, I guess. What are some of the issues with tramadol that we just have to be aware of? can lower the seizure threshold. So if somebody has epilepsy, I mean, it's not, I've never known or read, even other than clinical trials and animal research, about somebody who had a seizure from tramadol, but we know it can lower the seizure threshold. So if somebody has epilepsy, it's something that we have to watch, or not right for tramadol potentially. But this also has the warning of serotonin syndrome, because tramadol is a serotonergic agent, right? It's increasing serotonin. What else would be a serotonergic agent? Well, our Prozac type drugs, our fluoxetine, citalopram, escitalopram. So it's Celexa, Lexapro, Zoloft, Prozac, etc. These really, the biggest warning comes with our pure serotonergic agents, like our selective serotonin reuptake inhibitors, which were all the agents I just mentioned. This is the most common drug interaction that pops up in a pharmacy computer system, inpatient or outpatient, that we have to override as pharmacists. There's technicians that are usually processing the prescriptions, et cetera. And I mean, I staffed yesterday, and I must have had 50 times over the course of my 14-hour day, somebody'd say, got a major drug interaction. And 50 times, I bet you 40, maybe 44 out of the 50 times it was this drug interaction. So it also will pop up, if people are on drugs like Cymbalta, duloxetine is the generic, venlafaxine, et cetera. And that's less likely, but anything that's increasing serotonin is going to pop up as a potential drug interaction. Usually the pharmacist will make the assessment on their end if you've, written for tramadol and the patient's on other medications that can interact. But we also worry about it with like our triptans, some of our migraine medications. Usually I say 2 drugs together is probably okay in the large majority of people. 3 drugs together might be a little bit dicey. And you do not want someone to end up with serotonin syndrome, because it's better prevented, because it might kill them. That's never good. Tramadol was never a controlled substance for the first 20 years that it was available. And then in 2014, the FDA said, you know what? It's a mu receptor agonist, and people abuse it, take a ton of tramadol, and they get high. And people also use it so they don't go through drug withdrawal when they can't get their fentanyl or their morphine or heroin or whatever. So they did put it into a schedule of 4. Analgesic meds in pregnancy. I know it's a ton of information, but at least I'll keep you awake, because I'm talking fast and there's a lot to say. Analgesic meds in pregnancy. I mean, you probably could have said, oh man, I got a patient with pain and they, are pregnant. Most of the time we're going to go right to acetaminophen, right? Tylenol. And I mean, you can get a good amount of pain control with max dose of acetaminophen. And if somebody's pregnant, maybe that's where we want to go. Pause for one moment. You go back to the hullabaloo about acetaminophen use in pregnancy and, is it linked to autism? I mean, I think how that was handled, no political comment whatsoever. That's never going to be, my platform, nor will I tell you what you should think. But I will say I respect the sentiment behind it, but the execution was abominable, in the sense that you can't say in many, if not most cases, that if you take this drug, it will cause this. We can say things like, well, if somebody who's pregnant takes this medication, the baby might suffer from this. And, maybe we've seen it in small animal models, mice, and maybe rats or rabbits or whatever. And the reason why I just want you to pause and think through what I'm saying for a second here is because there is no drug that is completely safe. There is no safe drug in pregnancy. There are safer drugs in pregnancy. You might think it's a distinction without a difference. I disagree, because, when you have the one cell that splits into 2 cells and then 4 cells and then 8 cells and then 16 and then 32, et cetera, as those cells are dividing, those cells were made to be self-healing. So we are created as human beings to be self-healing organisms, and exposing cells to the minimum amount of chemicals possible is always going to be ideal. Do I think Tylenol causes autism? I know what studies the, RFK and stuff was referring to. No, and we still have to have choices for pregnancy, right? Okay, that would be my second TED Talk of the day. Second trimester, third trimester, first trimester, it depends. I mean, sometimes we have to use a non-steroidal. In first trimester, non-steroidals we should avoid because it can cause miscarriage. Later trimesters, it can be problematic because it can cause bleeding if somebody goes into labor. So generally, we're avoiding non-steroidals, not to mention premature closure of the ductus arteriosus, et cetera. But what about opioids? I mean, pound for pound, opioids are going to be safer in someone who's pregnant compared to non-steroidals, most likely. I mean, we're not talking high dose opioids over a prolonged period of time in a pregnancy, but maybe we are. I mean, I had a friend who broke her foot. She was pregnant. She broke her foot like almost completely off. The accident was so bad, and, had multiple surgeries while she was pregnant. And there were not a lot of choices for this horrific pain that she was in, other than opioids. So got to do what you got to do. All right. Here is kind of just my quick splatted on a slide, 2 slides. What would be used in mild pain, a 1 to 3 versus moderate versus severe on the next slide. And we're still doing good on time here. So mild pain is a 1 to 3. I mean, I'm a pretty tough gal. I live on a farm here, and it's just kind of how I'm programmed, right? I was daughter of a military guy that was like, mind over matter. It doesn't really hurt, even if it's severed and hanging off and hanging by a thread. So that's kind of just my thinking. So I look at something like mild pain. I'm not sure we need to treat a 1. I mean, that's just me. But the point is, a 1 is going to be different than a 3. I mean, I'm 56 years old. If I don't wake up with a pain that's a 2 or 3 on the scale every single morning, I'd be worried I was dead. It's just, comes with age as well. And that is a significant subject to at least consider as practitioners with prescribing privileges, because not every person that's in pain necessarily needs some big intervention. People get a little saucy, and this if it's happened to you, but they're coming in to see you as an optometric physician because their eye has a problem and it's causing pain, or even anything else, but not like a comprehensive eye exam. They're coming in for some sort of pain problem. They get a little saucy. People can get saucy if they're paying their copay to see you, and you're like, okay, well, I'm just going to tell you to, I'm writing it down on my little paper here, just go get some Tylenol. You probably have some at home, and take a couple Tylenol a couple times a day, and you're good. I mean, some people are like, you're not going to give me a prescription? I mean, I paid the copay. You should at least give me a prescription. Send Tylenol on an electronic prescription to us. Over-the-counter Tylenol. It happens all the time. You should make choices based upon what their pain level is, right? So these are just some of my ideas. Mild pain, acetaminophen, ibuprofen, naproxen sodium, all 3 of those over the counter, although you can get prescription strength of ibuprofen and naproxen. And then here's tramadol. I'm not even sure a 3 needs tramadol, but okay, if you had to box me in and say, give me 1 drug, I would say tramadol, maybe low dose codeine. Moderate pain, 4 to 6. Again, a lot of people would do fine on ibuprofen and or acetaminophen on a 4 or maybe even a 5. And even a 6. I mean, you do max dose Tylenol, max dose ibuprofen, you take that 6 down to a 1 pretty easy. Don't diminish the significance and the ability of the combination of acetaminophen and ibuprofen or even naproxen to really manage pain well. We should be thinking about our Vicodin, hydrocodone and acetaminophen products as severe pain. I mean, I grit my teeth greatly when I see prescriptions coming in because lots of practitioners will put pain scale actually in the directions on the electronic prescriptions or the written prescriptions. When people are like, take 1 to 2 tablets of Vicodin every 4 to 6 hours as needed for pain, moderate pain, 4 to 6. And I'm like, oh my gosh, we should not be doing that in 2026, because we don't know the people that are just going to have that like switch that's turned off in their brain or turned on in their brain, if you will, and then start seeking that addiction, chasing the euphoria. Okay. Tolerance, escalation of dose to maintain effect. This just means, and oh, by the way, tolerance does not mean somebody is abusing opioids. They might be. but tolerance is just as important in somebody who's appropriately using opioids. So that's an important consideration. Tolerance just means in order to have the same pain control I had when I started the opioid, 6 months, 6 years, 10 years, whatever, I need to increase the dose because my receptors have downregulated and our receptors are kind of like, I'm pretty sick of seeing you, morphine. So I'm just going to pretend you're not here. And we need more morphine in order to get that euphoria. But, euphoria if they're abusing it, or pain control. If somebody's got chronic malignant or non-malignant pain, they will have tolerance issues just like somebody who's abusing the opioid. And that's a hard thing to consider as a patient who's using it appropriately. It's a scary thing, and there should be a little bit of healthy fear when we're using these medications in practitioner and inpatient. So it's escalation of dose to maintain effect. That analgesia or euphoria, it happens to everybody. This euphoria and the tolerance with receptors is the dangerous part of people that are abusing the medications, or even those that aren't drug abusers but are like, oh my gosh, okay, I took 2 Percocet. It's, let's see, East Coast, it's 12:25. Okay, I took my Percocet at 10 a.m., but I'm having breakthrough pain now. I'm just going to take 1 more Percocet. It's been 2 hours, so 1 more Percocet or half a Percocet, I'll be fine. You might not be, Mrs. Smith. That you might be that half of a Percocet is what's going to throw you into respiratory depression, and you won't wake up. So I believe in scare tactics sometimes with patient counseling. And I say to a patient, do not take more than is prescribed with an opioid. And I say, if you decide that you need more pain control, then you need to contact your practitioner or go to urgent care or the emergency room if you can't get a hold of your practitioner. Because if you take an extra half a tablet of this oxycodone, that might be the amount that throws you over the edge and you stop breathing. People need to understand that sometimes a little goes a long way. Opioid side effects. Again, opioid receptors, top of head to the bottom of the feet and everywhere in between. Side effects, everybody will experience, and we have to anticipate it. I would say the constipation is still something to consider as an optometric physician with prescribing privileges for some of these products, because you take, well, let me take one step back. What are we talking about here? We're talking about all opioids, but for your purposes, it's going to be tramadol, codeine plus acetaminophen, or hydrocodone plus acetaminophen. Tramadol does not cause constipation in most people because even though tramadol is a mu receptor agonist, it's got that mixed mechanism. It increases serotonin and norepinephrine. Most people will say, I didn't notice, increase or decrease in bowel function when I was on tramadol. Tramadol also doesn't really cause sedation in patients like it does. Some people will say they maybe get a little dizzy on tramadol because you get the surge of serotonin and norepi, but it's a really well-tolerated drug. So constipation is going to be more of the codeine or the hydrocodone. If you have a patient taking Vicodin or codeine for 2 days, around the clock for 2 days for pain control, it'll shut down all gut peristalsis, and they probably will not move their bowels for the 2 days that they were taking the opioid, and for probably 1 to 3 days after they've stopped the opioid. Think of, I can't ask for a show of hands because I can't see you, but if I said, who has ever had diarrhea? I'd look for a show of hands and I would say, what did you take when you had diarrhea? And you would say, well, I had this over-the-counter product. It was lovely. It was called Imodium. Imodium is brand name. Loperamide is the drug. Do you know that loperamide is a baby brother of all the drugs that we just are talking about? That's why it works. Opioids stop all gut peristalsis. Fun fact, did you also know that you can get high on Imodium? I mean, you have to, suck down about 4 full boxes of the Imodium. Don't do it. Not suggesting it. I'm just saying you can get high from it. You go on all these weird websites that I look at as a pharmacology person, and people are like, yeah, if you take this particular generic brand of loperamide and you take 80 tablets, you can really get high from it. Don't suggest it. I'm just saying that That's the definition of addiction, compulsive use despite harm. So constipation, anticipate it. If somebody's going to be on opioids for 1 or 2 days, we don't have to address it, but people don't appreciate not moving their bowels for 5 days, so we at least should mention it. Stool softener is not going to be enough generally, because we are getting decrease or, complete shutdown of gut peristalsis. And you need a stool softener and a stimulant. And that gives you both the mush and the push. As grotesque as that sounds, that's literally what you have to think of. If you only have something that's softening the stool, that's the mush, but no peristalsis, it's going to be, 3 to 10 or 11 days of no gut peristalsis, where this soft stool is going to eventually make it through 26 miles of gut. Whereas if you have just the stimulant and no softener, you're going to have a hard football-like bowel movement that's trying to make its way, via peristalsis down to the end of the 26 miles of gut. And that also is not fun. So they work together. You get the mush and the push. I don't take credit for that. There's a pharmacy professor from 35 years ago, but you'll never forget it. Pruritus, some people itch from these. Nausea, vomiting. Remember, codeine's the worst. Sedation, inhibition of cough reflex, confusion, euphoria, etc. I already mentioned the respiratory depression. Meiosis is seen in pretty much everybody on opioids, no matter the dose, but profound meiosis, the quote unquote pinpoint pupils, usually high dose, light eyes, more pronounced. And they can get pretty small. So, if you come upon somebody while walking in the woods and they're not breathing, and you're somebody who carries Narcan like I do, call 911 for sure. They maybe need CPR for sure. But if you have Narcan and you decide to give it to them, can't hurt if they didn't overdose, but if their pupils are tiny pinpoint, it's a good indicator as well. And that's the beauty of Narcan. If you give it to somebody who is not breathing and they're there in front of you and you have no idea who they are or what happened, certainly do CPR, call 911, and you can administer Narcan. It won't hurt them if they didn't overdose. What else? So these are just a couple of examples I want to show you real quick of bad scenarios that you can end up in when we don't take tolerance and different chemical structures of opioids seriously. All right, this patient is an actual patient of mine a while ago. This guy has chronic pain. Significant back injury, fell off a roof, like a 2-story roof, years ago. Anyhow, he uses medication appropriately, but this is what he has. And you can see that he gets a 30-day supply. This is from the prescription drug monitoring program, which hopefully you all have signed on to if you've ever prescribed an opioid. So, these are the dates, obviously, the date written, the date it was picked up or dispensed. These are the day supply. So, he was regularly getting a 30-day supply, which is what you would get. He's getting Xtampza ER, which is a long-acting oxycodone. And he's been on the same dose of it for, 12, 15 years. I've known him for 35 years as a patient. But anyhow, he gets the same dose. He does get a benzodiazepine, which makes me nervous because a benzodiazepine, the PAMs are the lambs, right? The alprazolam, Xanax, lorazepam, Ativan, clonazepam, Klonopin. This is a bad combo, and it's almost malpractice in 2026. He's been on this combination for so long and has tolerance and never increases the dose. So I know him well, and I don't really make too much of a stink. But if he had been on this Xtampza, oxycodone long acting, it's easier to say, and I got a new prescription from the same doctor or any other practitioner, and it was now for a benzo, I would push back on that, and I would say not really comfortable dispensing that because of the additive effect of CNS depression and potential death. But he's good. So anyhow, he had a tooth problem, and his endodontist sent over a prescription for oxycodone and acetaminophen. So this was Percocet. And I was like, whoa. Called the patient and I said, buddy, you can't do this. You know that if you are on chronic opioids, that you've signed a contract with this practitioner on chronic opioids, you cannot get another prescription from another practitioner for another opioid. You signed that document, that opioid agreement or opioid contract. And he said, no, I know, but the dentist or endodontist spoke to my chronic pain guy, came up with a plan. I'm not going to take the long acting while I'm taking the short acting for this acute tooth pain. And, I called both prescribers, got the information there, documented the heck out of it, and the patient was fine. And, he's pretty good anyhow. Let's see. I'm not going to go through morphine milligram equivalent, but then I had another patient number 2. I just want you to see this. This patient gets oxycodone 30 milligrams. By the way, that is the number 1 oxycodone product that is sold on the street, because 30 milligrams. I mean, Percocet is 5 milligrams standard dose. So that is one. If I have drug seekers coming in or dealers coming into the pharmacy where I am, which we do on a regular basis because we're an independent with fake prescriptions, this is what they're looking for, 30 milligram tablets. Anyhow, so we didn't even stock it. But this patient was getting 30 milligram tablets, 210 of them per month. This patient was also getting methadone. Now, she definitely had an opioid problem that was, induced by the fact that her practitioner just didn't prescribe things appropriately. She should have never been on this, this number of opioids. But 10 milligram dose of methadone every day, or 10 milligrams, 180 tablets per month. So she was getting 6 a day. She was also on Ambien and also on Xanax. We ultimately said to this patient, apologizing to her, because I know she is truly a chronic pain patient, but we tried for so long, to get her better care. And, she was unwilling, and it was a mess. And her dose per day of, if she were taking morphine as an equivalent, it's 555 milligrams of morphine per day. That is the equivalent amount of all the stuff she was taking. If you gave her morphine, that's how much you would give her. That is enough to put down the entire Ringling Brothers, Barnum and Bailey circus elephant tent. It's just enormous. So it's tolerance. She's been mismanaged, et cetera. And we just said, from a liability perspective, we can't have you as a patient anymore. We really did try. That is crazy. You should not be at more than 50 in an outside scenario, because we know that if you're at 50 milligrams of what we call a morphine milligram equivalent, your chances are 25% higher than somebody who's on a lower dose in terms of accidental death due to overdose respiratory depression. And the FDA says if you're above 90, that you're in deep doo-doo in terms of your risk for dying from respiratory depression. And this is her baseline. This is every single day. So it's terrifying that no maximum daily dose of an opioid, this is where it can come and, burn a patient, unfortunately. So any CNS depressant is basic, generally a no-no in combination with opioids, but not all of these are created equal. When you look at alcohol or a Xanax type drug, these two in orange here, mixed with an opioid, that is Russian roulette for sure. And there have been many big, burly professional athletes that you're like, well, they weigh 275 pounds. They're a linebacker, for crying out loud. They'd be fine with 5 milligrams of oxycodone and 1 shot of tequila. And they proved that to be wrong. So you can't predict, who's going to have the problem. You have to be so careful. There's a lot of information, and it's all interesting, of course, on the history of opioid addiction. I just wanted to mention briefly that, there's different iterations, and, we sort of go through this, but, we've had multiple, and now we're in another humongous opioid epidemic for sure. And I wish I knew the solution. I don't know the solution to it. We know that there are opioid risk factors, and anybody that's going to be on opioids acutely, really, but definitely chronically, should be assessed for their risk to develop opioid use disorder or their, susceptibility to addiction. Because any drug that can give you a euphoria, tickles that dopamine reward that's like, do it again. Or you can call it the Pavlov's dog, the Pavlovian system, dopamine reward center, the hedonistic pathway, whatever you want to call it. That is a powerful, powerful pathway in the brain that can convince you it's a good idea to do it again. Don't forget about the prescription drug monitoring program. It is an invaluable tool. It is an electronic database that tracks controlled substance prescriptions, can help identify patients who may be misusing prescription opioids or other prescription drugs and who may be at risk for overdose. There's no negotiating with me when it comes to prescription drug monitoring program. So even just on the staffing side, if I get a prescription for an opioid, whoops, sorry, I went all the way back to the beginning. If I get a prescription for an opioid, I don't care if I know the patient, I don't know the patient, or whatever the scenario is, I absolutely will, I absolutely will look in the prescription drug monitoring program every single time. I might have 15 patients waiting and 50 prescriptions piled up next to me. I always look. And I can't tell you how many times I find a scenario where I'm like, whoa, this patient is getting 3 different opioids from 3 local prescribers, different practices, and they're also getting benzodiazepines. They're going to 4 different pharmacies because nobody's checking. There's not a centralized pharmacy system that's going to show you all that. Only the prescription drug monitoring program. It will not show you if somebody's using illicit opioids, right? It's not going to show you that. But it's so helpful, and it protects you from a liability perspective. So then I call these, I hitting the phone number to call the practitioner, and I'm like, did you not check the prescription drug monitoring program? And they're like, no, I was too busy. And I'm like, okay, well, the patient's, getting drugs from 4 other practitioners, and you just sent me over a prescription. Everybody's always grateful, but we have to protect ourselves as well as our patients. Last thing I'll show you here are the opioid antagonists. We've got naloxone, Narcan. Most people have heard of that. And, as practitioners, maybe you should have some in your office. I've got some in my house. We had a wedding here in October, my youngest daughter on the farm. And my husband's like, we should have Narcan. And I'm like, what kind of wedding do you think we're throwing here? And he's like, no, and he was right. I was teasing him, but we did. We had Narcan in 2 different places because you never know what young people are going to do, or old people, or everybody in between make stupid decisions, right? Or inadvertently take something that they didn't know. I have it in my car. I carry it with me. And it's great. You can get it from local health departments for free. It quickly reverses opioids. When you look at something like fentanyl or heroin or super, super high doses of opioids, 1 nasal spray, 1 in each nostril, 1 dose of Narcan may not be enough. But so I always carry 3 doses. But it's the only thing we really have to reverse it. Naltrexone, Revia also exists as an absolute or true opioid antagonist. They rapidly reverse the effects of morphine and other opioids. I always say, if you're going to find somebody that, I gave you the example of you're walking through the woods and you see somebody down and you start CPR, you call 911, then start CPR and give them Narcan. If you think they actually did, overdose, and you give them Narcan, give them the dose and then back away a little bit, because, somebody will start breathing and maybe for a split second be like, thank you for doing that. And then very immediately can become aggressive and combative because they are in full blown withdrawal now. And it's not a fun thing to be in. Lastly, as part of the category of my last comments here, we also have Suboxone, and there are some new products out there, interesting, biochemistry, non-opioids, M1 receptor agonists, et cetera. But, we're looking at opioids here. We have Suboxone, which is a combination of buprenorphine and naloxone. So it has Narcan in it, and then it has this buprenorphine, which is an opioid agonist antagonist. So it's an opioid agonist antagonist plus an antagonist. I need more coffee to kind of, sort through that. But it also is a great drug. And, many of people's lives have been saved and changed because they used Suboxone or methadone. Signs of an overdose, there's lots available to you as practitioners, and, learning a little bit can save somebody's lives. So, if you come upon somebody or someone or don't know, and, slow or shallow breathing, could be a head injury, it could be an opioid overdose, unresponsive, or, the preamble to all of this might be dizziness or confusion. emergency response, et cetera. And then there's information on, naloxone, Narcan, and kind of, it's AI version, but just to kind of show you how to use it. It's quick, it's easy to do, and certainly can save somebody's life. Last comment in the 1 minute I have left. Don't get bullied by patients. People can be bossy. You have a gut feeling, and we have this gut feeling because it kept us alive, thousands and thousands of years ago. And it's the same reason now. If you're like, I can pick them out, I'm telling you, I'm pretty much 100% at being able to pick out the people that have drug-seeking activity or that are, trying to try me on to get drugs because I've done it for so long. But fast talkers, kind of keep you distracted, strange allergies. Like I had a patient who said, "Oh, I'm allergic to oxycodone, so that's why I have to take Percocet brand." And I was like, there's oxycodone in Percocet. And they were like, oh crap, I've been caught. They wanted the brand because it's got a higher street value. Or excuses as to why they've lost the medication. I mean, I say everybody can lose a medication one time. Any more than that, you have to ask. So use your best judgment, and always remember that nobody should be in pain, but we have to be careful as practitioners for sure. And I think that is the perfect place to stop, right at 12:45. Thanks, everybody. And we'll look at some questions if any of them have popped up over the past hour and 45 minutes.
That was fantastic. Thank you. As always, you're amazing. You just bring such a great wealth of knowledge to us, and you inject some humor in there. I was over here laughing a little bit too.
Thanks. Well, I love teaching.
Well, a reminder, please put those questions over there because we do have a few minutes and we have Dr. Offerdahl here. So take advantage of that. There was a question. Can you comment on Jornavix, please? Oh,
it's interesting. That's one of the ones that I was thinking of when I said newer medications. So that's one of the newer medications that's out. I've seen it used a couple of times. It is a non-opioid. And it is for chronic pain. I would say the biggest issue that we have with that particular medication is, we don't really have a longitudinal perspective on it. It's being marketed predominantly for kind of chronic pain in older patients. And if you forgive me here, I want to look up the price of it. The biggest issue is we can't get insurance to pay for it. So I have two patients, both elderly with chronic pain. Neither one is malignant pain, but it's costing them $700 a month, which is a disgrace. So you guys know, just like everybody as practitioners, when new drugs come out, you have some of the most fascinating and fantastic medications that have come out for optometry patients. Insurance just doesn't want to pay for them when they're first out, but much safer drug because you don't have the respiratory depression associated with it, et cetera. So I think we're going to see more of it used. I get a little nervous with new medications, like I said, because maybe we've only looked at them in 3,000 patients through clinical trials. But, I think I'm cautiously optimistic with some of these newer agents.
There's a question. Are you familiar with the recent study published in the BMJ that found tramadol was no better than a placebo and had greater addictive qualities than earlier thought? There were over 6,000 patients in this study. What are your thoughts?
Yes, I am. And so here's the thing. I think there is much more interpatient variability than can be addressed in, studies, et cetera. And what I mean by that is, if I ever have a renal colic thing, for instance, that is not covered by my spinal cord stimulator, I'll take 2 tramadol. Do I notice massive improvement like I would on oxycodone? No, but I do see better improvement than if I had just taken ibuprofen plus acetaminophen. I could tell you that, I could come up with 5 patients off the top of my head that have said to me just in the past month, I sometimes think that I take the tramadol because it really didn't help me at all. And a lot of it has to do with just our biochemistry as well. And I'll also say, it's one of the main reasons why I remind people, you take max dose ibuprofen and max dose acetaminophen, if that can be a choice for your patient, that also in clinical trials, multiple, has been proven to be as effective pain control as morphine. normal dose of morphine. Maybe doesn't last quite as long, but we have pretty wide prescribing ability there, right? I mean, you can give it every 4 to 6 hours, the max daily dose. So, it makes me a little afraid when we see studies like that, that I think it was a very valid study for tramadol, only because then people are going to automatically think, well, tramadol's out, so I'm just going to go for, a pure opioid agonist without that serotonin and norepinephrine. So it's a double-edged sword. The addictive quality, I 100% agree with. I remember when tramadol first came out and I was reading the pharmacology. It was a resident at Temple University Hospital. And I was like, how can this not have control, like be a controlled substance at all? And once again, it was a small number of patients. And it took, hundreds of thousands, if not millions of patients before we were like, gee, this does have some addictive qualities. But again, I think there are specific polymorphisms that are probably more likely, and other issues that contribute to addiction. But yeah, that's a good question. Thank you.
What are your thoughts on kratom? I don't know if I'm pronouncing it right. Kratom, and the interactions or combinations of other opioids.
Oh, I'm doing a talk on this here in the next few months. I mean, I'm no expert on kratom, but from a drug interaction perspective and, some of these other substances that people use, the cannabis area is something that, definitely needs to be explored. The problem is there's no standardization with some of this. But I think of it more as we're probably going to see standardization of some of these products, but this particular drug in general, I think can be terrifying in terms of drug interactions with opioids and other CNS depressants, or even can cause, like psychotic issues in some patients. So, but I think we have an opportunity to explore these, for potential use if we can get standard products for patients.
Perfect. So last chance to ask those questions. I don't see any more in there. I do see a comment that somebody else found that Jurnavix was ineffective in treating their pain as well. So I did see a comment there. Yep.
Yeah. And I think we'll see more of it.
Yeah. So, well, it looks like all of the questions have been answered. So thank you again for being here. Thank you for kicking off our Cozy Pharma weekend. As always, it's always a pleasure to have you here. For everyone, don't leave. We're going to take a short break. If you're on the East Coast, go grab some lunch, go grab a cup of coffee. The QR code is here, so make sure you scan that. And we will be back here at 1 p.m. Eastern. So go ahead and grab your coffee, and we'll see you back in just a minute.
Thanks, everyone.
right. How are you, Dr. Lonsberry? Let's see. All right. You can hear me, right?
Yep. Sorry.
Oh, phew. I was like, oh no. Well, welcome back, everybody. Thank you for joining us for the first half of our Saturday part of Woo You Cozy Pharma. Hopefully you all got a snack, or if you're on the East Coast, you had some lunch. But we are back here with part 2. So when drops won't do it, oral meds and eye care with Dr. Blair Lonsberry. I am still your host, Dr. Jennifer Stewart. Just some reminders if you didn't join us in the morning, but for a CE certificate, let's see. Hold on one second. I lost my screen. There we go. I had it memorized in the old platform, but not the new one. For a CE certificate, please fill out the survey. The link will be in the chat and emailed to you after the event concludes. Another reminder, this is a 2-hour session, so you have to be online for a minimum of 1 hour and 40 minutes. CE certificates will be delivered via email and sent to ARBO with your OE tracker number. Please allow up to 4 weeks for those certificates to be emailed. A QR code will be displayed at the end of the event, so you can use your OE tracker app. Make sure you use the Q&A portion. We will have plenty of time at the end. So Q&A and handouts can be found on the right-hand side of the page. To minimize, use the down arrow. To open, use the chat button. Dr. Lonsberry, welcome again. Another
Thank
favorite.
you.
We're happy to have you here. He grew up in Rossburn, Manitoba, obtained his optometry degree from the University of Waterloo in 1996 after completing a Master of Science in Physiology from the University of Manitoba. He completed his residency in primary care optometry from the Illinois College of Optometry in 1997, and then joined the faculty at Southern College of Optometry in Memphis. During his time at SCO, he completed a master's in education degree with an emphasis in adult learning. He's currently a full professor with Pacific University College of Optometry in Oregon, where his primary teaching responsibilities are supervising interns and overseeing a specialty lumps and bumps clinic. In his spare time, he goes to Anchorage, Alaska, where he sees patients in a private practice. He's a diplomate of the American Board of Optometry, a fellow of the American Academy of Optometry, the Optometric Retinal Society, and the Optometric Glaucoma Society. Welcome back to Woo You. I'm going to turn it over to you, and I will see you at the end.
Thank you, Jenna. Hopefully you guys can see my PowerPoints. And if you do, you'll see a polling question or to log into my poll everywhere. So just grab your cell phone, click on the QR code there, and that should log you in.
I don't see it yet.
Okay, let's try again. Share screen. Let's try this.
Okay. There we go. We are good. I see it now.
Okay, perfect. So if you would click on the QR code there for me, we'll get logged into the polling system, and I have some questions for you during the presentation. You can also log in via the web too, if you want to type in pollev.com/Blair Lonsberry. And if you don't get logged in right now, when the questions are running, there's usually a little QR code on the top as well. All right, hopefully I have a few of you logged in. So we are going to really be covering oral pharmaceuticals. Topicals, we do topicals pretty well, but when it comes to oral medications, I think sometimes we tend to hesitate. So what I want to do is focus on conditions where oral medications are going to be indicated. And we'll start off with a case here to start with. This is a 20-year-old male patient presents with a red painful eye. In your office, I suspect you have, your staff answering calls and for potentially emergency patients. I work also in a practice up in Alaska. So when I get a break from the school here at Pacific, I go up to Alaska and I practice there. And we have probably 7 doctors at any one time that's on every day. So when we get emergency calls, the staff actually has a triage form. And on that triage form, there's certain questions that are asked. And then that form actually has to be signed off by one of the doctors. So if we see a red form going around, we know that that's actually an emergency. And on that, we ask certain questions like, if it's a painful eye, when did it start? Have they done anything to kind of make it better? So questions we would typically ask would be is, when did it start? Well, in this case, it started that morning. If a patient has any type of discharge, so in this case, watery discharge, I tend to always ask if they're a contact lens wearer. We don't want to see all red eye patients, but in particular, we want to see patients who are contact lens wearers because there's some particularly nasty bugs associated with contact lenses. In this case, there was no itching. You can see the sodium fluorescein staining that's present. So my first question for you is, what is your preferred treatment for this patient? Again, if you haven't logged in, the QR code's up there on the right. All right, let's see what people are thinking here. All right, so I got a majority going with both oral and topical. The next big group is valacyclovir, then kind of a smattering of all the rest of them. So what we're dealing with here in this case is herpes simplex keratitis. With the HEAD study, which is the herpes eye disease study, which is probably almost 30 years old now, at that time we had trifluridine or Veroptic to treat. When they added in oral acyclovir to the mix, there was no additional benefit to treatment. So in my mind, you choose either one or the other. Choose either an oral or a topical. You really don't need to do both. There's no additional benefit by having both into the mix. At this point in time, almost all of us are really using oral medications. Topicals, when we talk about Veroptic or trifluridine, it's actually preserved in thimerosal. And thimerosal, what do we use thimerosal for nowadays? Well, nothing, because we found out it's toxic. Ganciclovir, great medication. Downside to ganciclovir is a cost. It can be upwards of $375. Now, I have recently found out from a student actually that if you go to GoodRx, that with ganciclovir, kind of the first time treatment, they can get it for a much reduced price. I think it was, I don't know, $25 or $30. So you might want to try GoodRx for a patient that you want to get on ganciclovir. Again, I'm not too sure if it's universal, but we had a patient here that we were able to get it on for a relatively inexpensive price. Oral acyclovir, oral valacyclovir, and then oral famciclovir are our big three oral medications, and I'll talk about those more in just a sec. So when we talk about herpes simplex, there's the two types. There's HSV1 and there's HSV2. Majority of people who have cold sores, that's HSV1. The genital herpes is HSV2, but it really doesn't make much difference. The genetic variability between those HSV1 and 2 is pretty minimal. So you're gonna have people that have HSV2 that have the cold sores, and there are people who have genital herpes, which is HSV1. Generally, HSV1, we get it typically as a kid, get in contact with it, goes up to the trigeminal ganglion behind your ear, hangs out there until you become immunocompromised in some sort. You develop a cold or a flu, or you become stressed, and then it manifests as a cold sore. Well, that cold sore can also end up on your eye. So at that point we're talking, that's HSV keratitis. People, when they get exposed to the HSV virus when they're young, 90% of them are asymptomatic. Very few people have any type of symptoms related to being exposed to the HSV virus. Only about 5% of primary infections result in really any ocular involvement. So it's unlikely you're going to see those. What we see in adults is the reactivation of that virus. And that's again because it's kind of moved into the trigeminal ganglion behind your ear and then reactivates. When it does reactivate, it's almost always unilateral. It's very uncommon to have a bilateral presentation. So only about 12% of cases are actually bilateral. And if you do have a bilateral presentation, you really do need to start looking into their immune system. We tend to see bilateral presentations in patients who are immunocompromised. And the other one that can be a bilateral presentation is potentially kids too. So they have a hyperimmune response. But with bilateral cases, I'd be a bit more concerned about an immune condition. So we know that stress, UV radiation, hormonal changes can reactivate the virus. And then in particular, we have to be concerned about our patients who are immunocompromised. So patients who have gone through organ transplantation or going through chemotherapy, potentially HIV patients, that they potentially can even have a bilateral presentation. So when we talk about red eyes, there's literally 50 different causes for a red eye. So what we need to do is to get into kind of more signs in this case versus symptoms. Patient's symptoms of ocular irritation, redness, photophobia, watering, blurred vision, really that's pretty much every red eye. That's not really going to help you very much. So what we do is go for those signs. And when we saw in the previous picture, we saw that kind of dendritic pattern. That's a true dendrite. True dendrites have ulceration to the middle part of it, and then they have these terminal bulbs that tend to stain with your rose bengal or your lissamine green. When you say dendrite, you're telling me that this is HSV keratitis. No other condition has a true dendrite. When we talk about zoster lesions, they actually tend to be a heaped up lesion, not necessarily an excavated ulcerative lesion. So we're looking for that central ulceration, and we're also looking for the terminal end bulbs, and that's classic for HSV keratitis. Interesting enough, though, when it comes to HSV keratitis, it can almost look like whatever it wants to. And if you talk to a corneal specialist and you refer a patient over for kind of an unspecified corneal condition, they assume it's herpetic until proven otherwise, because it really can look like whatever it wants to. Now, with that bottom statement there, the corneal sensation is reduced. It will be in those patients. It's not something I typically do on patients. So if I see a lesion like this, I know it's herpetic. But if I see a lesion like this, I'm not sure that's herpetic. This is a geographic or an amoeboid ulcer. This is what happens if you let these previous lesions go. It'll actually kind of take over the entire cornea. So for this could be really challenging to say, well, that's not my classic dendrite. What is this? So if you do corneal sensation testing on this patient, it actually will be reduced. Now, if there's also an anterior chamber reaction, when we tend to think about anterior chamber reactions in an acute onset iritis, IOP tends to go down. The exception to the rule is in patients who have herpetic infections. If they have an anterior chamber reaction with this kind of corneal presentation and their IOP is elevated, it's a really confirmatory for you that it's actually herpetic in nature. They end up developing a trabeculitis with this, which results in an IOP going up instantly. So if you see kind of this kind of unusual, or you're not really convinced it's herpetic on the cornea, but you see an elevated IOP associated with an anterior chamber reaction, and it kind of really does confirm to you that it's actually herpetic in nature. All right, my next question for you is, what is the proposed recurrence rate of HSV keratitis in the pediatric population? Now, I'll admit I don't do a ton of pediatric patients, but if you do have a pediatric patient, so say you have a 2-year-old, has had a bout of HSV keratitis, what's the likelihood that they're going to actually have a recurrence of that HSV keratitis? All right, we'll wait for a couple more seconds here, get a few more people answering. All right, let's see what people are thinking. Correct answer is actually D, it's 80%. So probably obviously much higher than most people think. When we talk about adults, from the head study, it was about a 37% recurrence rate. So about, just over 1 in 3 patients are going to recur as an adult. So why do kids have an 80% recurrence rate? And it's because they actually have a hyperimmune response to the HSV virus. So when we talk about recurrence in adults, it's typically the stromal disease. Now, thankfully for most adults, they just stay with the keratitis component, but kids go stromal 75% of the time. And that's what's going to increase their chance of having a recurrence. So if you do have a pediatric patient who has an HSV keratitis, there's a high probability that they're going to recur. With that, you can have, again, with recurrent bouts of it, have a result in corneal scarring, which can result in weird forms of astigmatism, and they can develop an amblyopic component with it as well. And just think again, with your 2-year-old coming in, they're going to sit perfectly in your slit lamp. You can put your stain in. They're going to have their eyes nice and wide open, and they're going to let you look. Well, kids can also be challenging to examine as well. So the thought is that there's about a 30% misdiagnosis rate of herpetic keratitis in kids because it's just really difficult to examine kids. So if you have a recurrent unilateral red eye in a child, you do need to think about it being herpetic in nature. So then that brings up is, what do we do for them? While we know that prophylaxis tends to work for adults, and it will work for kids as well, the downside is we don't know how long they need to be on that prophylaxis. So again, practicing up in Alaska, one of my colleagues up there who does most of our pediatric work had I think she was a 5-year-old, had herpetic keratitis, sent her to the pediatric ophthalmologist who put the child on prophylactic acyclovir, and didn't kind of really explain to the parent about why they needed to be on this prophylaxis and why they needed to continue to take the medication. And so the mom ended up stopping it, and she rebounded right back. So with kids, the thought is probably at least a minimum of a year on prophylaxis, and it could be longer than that. It could be 2 or 3 years. We just don't really know. So for our topical medications, we have the main two, which is Veroptic or trifluridine. One of my pet peeves is that people say it's 9 times a day, and it's really not. It's actually every 2 hours to a maximum of 9 times a day. Because of its toxicity, if a person gets like 4 drops in and it's 7 o'clock at night, I don't want them putting in another 5 drops because it's just way too toxic. So it's every 2 hours to the epithelium heals, and then taper it down for probably 3 to 4 times a day for the next kind of couple weeks. Ziragan or ganciclovir, it is available. It is not necessarily available in pharmacies right off the bat. So sometimes you might want to have a pharmacy that that stocks it. Again, look into the GoodRx and see whether or not you can get a lower price for it. It is 5 times a day until the epithelial lesion heals, and then drop it down to 3 times a day for the next week. So when we're talking about oral medications, let's think about what happens when you swallow a medication. So when you swallow medication, obviously it has to go into your esophagus, it goes down into your gut, then it's broken down by the gut, and then it's absorbed by either by the GI lining or the intestinal lining. And a lot of times we want medications to be absorbed by the intestinal tract because there's about 1,000-fold increased chance for absorption through the intestines. But after that, what it does is it goes to the hepatic portal system. So it goes to the portal circulation into the liver, and then goes through first pass clearance through the liver before it gets into the circulation. So we have to kind of figure out, well, how much is actually getting broken down by the gut, how much is getting absorbed, and how much is getting into the circulation. And that's the challenge. We need to figure out how much is actually getting into the circulation to take care of whatever we're taking. So that's effectively bioavailability, what's in the circulation to treat whatever infection we're dealing with. Well, if you want to increase bioavailability, what you need to do is actually bypass the hepatic portal system. So that's why we have IV medications. That's where you can see up there by nasal stuff, so snorting things, or sublingually. It actually gets into the circulation directly and bypasses the hepatic portal system. It's why people snort medications, is because they get into the circulation directly and they bypass the gut. So when it comes to our oral antivirals, again, our main 3 are acyclovir, valacyclovir, and famciclovir. Well, acyclovir and valacyclovir are the same drug. They're both acyclovir. However, valacyclovir is a prodrug of acyclovir. So it actually converts into acyclovir once it gets absorbed into the system. And we like prodrugs because we increase bioavailability by that. We're not waiting for it to be broken down by the gut. We're not waiting for it to be absorbed into the system. Once it gets absorbed, then it gets converted into the active component. So when we take acyclovir, which is a very safe drug, only about 10 to 30% of it gets absorbed, which means that probably bioavailability of that drug, of whatever the original dose you took, is probably about 20% once it actually gets into the circulation. It also has a pretty short half-life. It's metabolized pretty quickly. And so that's why it's 5 times a day dosing, is because you have to have it in the system long enough in order for it to be effective. So traditional dosing for Simplex is 400 milligrams 5 times a day. For Zoster, 800 milligrams 5 times a day. That's kind of our standard dosing. However, I will say that I pretty much do Zoster dosing for almost all my patients. It's not going to hurt them. And in addition to that, you're getting additional medication into the system. So I pretty much remember Zoster dosing because that's what I tend to prescribe, whether or not it be Zoster or Simplex. Now, valacyclovir, again, is a prodrug. It converts into acyclovir at a 95% conversion rate. So at that point, you can see it's 3 times a day dosing versus the 5 with acyclovir because it just lasts in the system longer. In addition to that, it's also at a higher concentration. So bioavailability of what you take in is probably closer to 60 to 70% versus the 20% if you just took acyclovir. Now, the last one is famciclovir. I can admit that I've never worked with famciclovir. It's not something I've ever tried. Typically, we're in the acyclovir, valacyclovir, and famciclovir is generally reserved for those patients who don't respond to valacyclovir. It's actually a prodrug of penciclovir, and penciclovir is about 10 times more potent as acyclovir. Again, why its dosing is 3 times a day, again, is because the fact it's just in the system longer and at a higher dose. So for valacyclovir dosing, 1 gram for zoster, 500 milligrams for simplex 3 times a day. For famciclovir, 500 milligrams TID for zoster, 250 for simplex. Again, if I'd remember the zoster dosing, that's probably where most of us are going to prescribe at that point, because it's not going to hurt our patients. These are actually relatively safe drugs. The question I typically get asked is with acyclovir in patients who have kidney issues. Yeah, I certainly think I'd be concerned about that, but patients actually have to have a really significant kidney disease, and they have to be actually a really high dose, probably almost to IV dosing, before you're going to start resulting in more kidney damage. But ultimately, if the patients have chronic kidney disease, you might be wanting to talk to their nephrologist or their primary care physician before you start prescribing. Stromal disease, this is the one we kind of get worried about for patients, because this is going to want the form that's going to result in scarring. Now we have an inflammatory component in the stroma, and it can result in scarring. And with these patients, this is what's also going to cause the recurrence. This is what's going to cause these patients to have repeat bouts of it as well. Now, in optometry school, all of us learned, don't ever put a steroid on what you think is herpetic in nature. Well, I think I have a better rule for that one, and that rule is don't put on a steroid when you think it's herpetic unless an antiviral is in play. In particular, you want an oral antiviral in play. So from the head study, you can see down below here, they were using prednisolone phosphate, which we don't tend to use, but with stromal involvement, you're going to have a steroid in play, because that's the only way you're going to get rid of that stromal inflammation that's there. So the recommendation is that with a defect or without a defect, is still the use of a steroid in addition to the oral antiviral. Now, if you can, you'd want to start the oral antiviral prior to initiating the steroid. But generally, you would always want to wait till the epithelial lesion heals, and you don't necessarily need to do that in this case. You just need to initiate the oral antiviral probably for a day or two if you can, then start the steroid into the mix. If you don't add the steroid in, then it's going to result in scarring. They're going to get hazing of the stroma in that area. So again, start your oral antivirals. Hopefully wait a day or two before you can start the steroids, but you do need the steroids in the mix. From the head study, again, they use prednisolone phosphate. We don't really use pred phosphate for much of anything, so you're going to want to have something stronger than that. You can go into prednisolone or potentially Lotamax or FML. You're going to need a bit more powerful steroid than prednisolone phosphate. And your initial dosing is going to actually be relatively high, because you want to be able to get that inflammation under control as quickly as possible. Now, from the head study, remembering that they were using prednisolone phosphate, their topical steroids were for about 10 weeks with the oral antiviral. Now, that's not full dosing for the entire 10 weeks. It may be that you're dosing them, relatively high for the first week or 10 days until you get the inflammation under control. And then it's just a really, really slow taper through the next time period. Again, it's going to vary a little depending on what steroid you're using. Again, that 10-week time period was based off of the use of prednisolone phosphate. So your timing might be a little bit different, but they absolutely need to be on the oral antiviral for that entire time that you're dosing the steroid. With HSV keratitis, your kind of options-wise, if you're going to go topical, then I certainly would be looking into ganciclovir. Better dosing, less toxicity. Majority of us now, I haven't prescribed a topical for probably 10 plus years. So oral valacyclovir is my go-to. Again, its traditional dosing is 500 milligrams 3 times a day for 7 to 10 days. I also have no problems if you're going to do 1 gram 3 times a day, extra medication in the system. Lubrication drops because the eyes like to be comfortable. L-lysine, you might have heard about this. L-lysine is actually an amino acid. It has been shown to have the ability to retard growth of the herpes virus, so it kind of shuts down replication. I've never used it as a treatment option. I have used it in prophylaxis for patients, but I've never used it as a treatment option. Debriding the ulcer, I will do this for patients, but when I say debride, I want you to be kind of really, I want you to listen to me on this one. No sharp instruments. You're not using your algae brush. You're not using a golf club spud. You're not using a needle. What you're effectively doing is prepare cane and taking a cotton swab. And what you're going to do is just kind of peel off those active viral particles that are there. It's basically necrotic tissue. So when you do it, it just sloughs off almost like cellophane or saran wrap. So again, no sharp instruments, just anesthetic, cotton swab, get rid of those active viral particles that are there. It doesn't make the wound heal better. It just gets to the end result quicker. So in other words, you can potentially make the patient heal a bit quicker. The end result is going to be the same. So with or without the debridement, they end up in the same spot. You just might get there a little bit quicker. But again, no sharp instruments. Prophylactic treatment. The head study did show that there was a reduction in potential recurrence by about 50%. Now, when the head study, they did a year-long post. They watched patients, and then one group got obviously prophylactic dosing, the other one didn't. And there was a 50% reduction in chance for recurrence, which sounds great. But remember that your patient's chance is only about 37%. So it drops it down to about 18 to 19%. And as soon as they stop taking that medication, their recurrence rate goes back as if they've never taken the medication. So if we go back to our original case, which is a 20-year-old, you're saying for the next 70 years, you're going to take this medication every day, and you're not going to miss a day. Well, what's the likelihood of that happening? Well, we can't get our patients with glaucoma to take their medications, let alone someone where you're saying you've got a 30% chance that you're going to recur. So there's kind of really 5 groups of patients that we recommend prophylaxis for. They've already had recurrent bouts, and they're starting to get stromal scarring. They have bilateral involvement. They have a PK or a graft. They're a monocular patient. And your 5th one is your pediatric group. Because of their high recurrence rate, they're going to need to be on prophylaxis after that. The question is, we just don't know how long they're going to be on it for. So again, those 5 groups, the patients already have recurrent bouts and have scarring. Bilateral involvement, and I would also be checking their immune system. They've had a PK or a graft done, they're monocular, or they're a pediatric patient. Pitfalls of prophylaxis, again, because this is a virus, viruses like to adapt to things. They've already found resistance to acyclovir. So again, we want to use it for those patients where we know it really needs to be used for. We don't want patients taking it for a month and then off for a month and then back on it again. All right, let's talk about acne rosacea. So with rosacea, I don't know what it is recently, but I'm starting to see a lot more patients coming in with rosacea and who don't necessarily know that they have rosacea. And the last patient I had come in, I was working with one of the interns, so I teach at the university and I primarily work in clinic with interns. And when I walked in, I could see that she had some kind of just redness to her cheeks and so on, and had a complaint of dry eye. And the intern really kind of didn't say anything to me about that. And when I walked in and I said to the patient, I'm going, yeah, we're talking about your dry eye. And I said, you got your flushing on your cheeks here. I said, does it get worse with heat? Do you have any other kind of triggering events? And she basically broke down in tears and saying, this has been really bothersome for me. No one's been able to tell me what it is. It's embarrassing and all the rest of it. And so she seemed to be really appreciative of the fact that I actually noticed it and then acknowledged it and said, well, there's stuff we can do for that. So I think it's one of those conditions that patients have that is really kind of not diagnosed until they see an eye care professional. You can see those telangiectatic vessels there on that lower lid. Hallmark sign of rosacea, the telangiectatic stuff that comes across, that inflammatory component of which results in almost all patients having some form of dry eye. I have a lumps and bumps clinic, so a specialty periocular clinic. So I have a lot of patients coming in who've got like lesions on their lids, etc. And one of the patients I had in my clinic there came in with a mask on, which was fine. But it wasn't because she was doing it for, respiratory things. It's because her face was so red with rosacea that she was wearing the mask to cover that up. So again, there is a lot of kind of patients just notice it and are self-conscious about it. So I think us addressing it, not only from the dry eye component, but also from the cosmetic kind of approach is important for patients. So with women, it tends to be over their cheeks, maybe a little bit over their nose. And men, it tends to be over the bridge of the nose, up over their brows. What's interesting is if patients don't even necessarily know that they have rosacea, but you ask them what their triggers are, they know what their triggers are. They know what causes that flushing. So they know that heat will do it, spicy foods will do it, sunlight will do it, basically being alive will do it. If you didn't want to have a flare-up of your rosacea, you need to not eat or drink anything and stay in a dark room all the time. Because pretty much everything else is a trigger for it. We also know Demodex is a huge player for rosacea. And you can see here, we don't necessarily always have to pluck the eyelashes. Basically, just what you need to do is twist them. When you twist it, you can see that the Demodex comes out. And as we continue to twist, There's actually a second one there. And there's the second one. All right, so we know that Demodex is a huge player. We're not really sure whether or not it's truly the Demodex or whether there's actually little bacteria that live on the Demodex, whether or not that's the trigger for rosacea. But either way, Demodex is a huge player for it. Now, obviously, we're not as worried about the eyelashes. We're more worried about the Demodex that's in the skin. So we need to also address the Demodex because I do think Demodex is a big player for activating patients with rosacea. We know with patients with rosacea that we want to kind of intervene as early as we can. So even patients who have, say, mild disease, we want to start talking to patients about ways to minimize the redness, minimize the progression of the condition. So, talking about, certain cosmetics they're going to use, skin creams, avoiding whatever triggers they can potentially avoid. So things like, sun protection, gentle skin care, cosmetic products, etc. When it comes to treatment options, we do know that we need to kind of have some type of anti-inflammatory therapy in place. So doing systemic things like omega-3s and so on can help with that. Hypochlorous acid contains anti-inflammatory and antibacterial properties, which might not only help for kind of some of the inflammatory stuff, but maybe be helping with Demodex as well. It's nice that here in the US, we now have a treatment for Demodex, which is Xdemvy. I have used it several times and have had really good success with it, particularly for patients who've got, Demodex on their eyelashes. I had a patient that came in with basically 4+ Demodex, like every eyelash had a collarette on it. Had them do it, come back 2 weeks later, and it was completely gone. So remember, it's twice a day dosing for the entire 6 weeks. You don't only necessarily want to kill the ones that are there, but also their eggs. So it takes a 6-week time period for that. Last time I talked to Tarsus, who has Xdemvy, they were actually working on a gel potentially for rosacea. So hopefully we'll get that as well. The systemic treatments, so things like your tetracycline group. Now remember, we don't use tetracycline anymore. It's kind of weird when there's a name of an entire group. There's also a name of a product in the group. So again, tetracycline is the name of the group, but it's also the name of a product in that group. And we don't use tetracycline. It's just too difficult to take. It's 4 times a day dosing, an hour before you eat or 2 hours after. So it's just a really challenging medication to take. So most of us are using either doxycycline or minocycline. And what we're using those for is their anti-inflammatory properties. We're not using this as an antimicrobial agent. So dosing for doxy for antimicrobial properties is 100 milligrams twice a day. What we're using it in this case is 50 milligrams per day. And what we're doing is we're subclinical for killing bacteria. If you start killing bacteria, particularly on the face, then you can actually have other bugs come in and take over. So we don't want to actually kill the bugs that are there. We just want to shut down their inflammatory properties. So in this case, there's actually a product called Oratia. And Oratia is 40 milligrams. It's not necessarily a cheap program, but it's designed, or pill, but it's designed for acne rosacea. So most of us use 50 milligrams of doxy, using it once a day, typically for a couple months in order to try to get, the inflammatory component down in patients. Then hopefully at that point, they can kind of keep the redness down by doing other things. Remember that you're not killing bugs. So they can actually be on this for prolonged periods of time without developing any resistance issues. Now, one of the products that's been found to be really effective for patients to prevent their redness and also potentially helping with the rhinophyma type stuff is actually topical bromonidine. This is a bromonidine gel, not what we use for glaucoma, but in this case, the Movazzo topical gel, it's used for topical, again, not oral or ophthalmic or intravaginal use. It's really used on their cheeks. The downside to this one is it can be a pretty pricey product as well. So again, you need to check to see whether or not patients can actually afford it. Most of us now are getting into light therapy, so doing IPL, et cetera. That is actually very good for patients who have rosacea, particularly when they have telangiectatic vessels. It's extremely good for taking care of that. Again, we're not sure whether or not it's actually killing the Demodex or basically the bacteria that grows on the Demodex, but light-based therapies are actually really beneficial for patients, particularly if they have any of the telangiectatic vessels. All right, so a patient is suffering from a thermal corneal burn and rates her pain 8 out of 10. Now, this is a patient I had during my residency, which was a few years ago now. At that point, I was still rocking the pager, so I got paged called her back and she said, I rolled my curling iron onto my front part of my eye. Obviously it hurts. And I said, so you're on your way in, right? And she goes, no, I got to go to work today. I'll see you about 4:30. I'm going, yeah, you're not likely going to make it to 4:30. So by about 9 o'clock, she was in the office because she was in so much pain. So what are you going to recommend for her pain management? There's a lot of choices here. So I'm going to give you a few seconds here to look at those. All right, give me a couple more seconds. All right, let's see what people are thinking here. No one chose a nucleation. I'm a little sad about that. Majority chose 2x325s of acetaminophen, followed by 2x200s. So that's our kind of standard dosing for pain management. The downside in this case is, remember, her pain is 8 out of 10. I'm not sure that I'll get over the 8 out of 10 pain threshold. That will probably take care of it's in the 5 or 6 range, and don't know if it's going to get over that 8. So what we need, I think, need to do is actually go to something a little bit stronger than that. So some are doing Tylenol 3, and that's actually what we did, was Tylenol 3 for her. But at this point in time, I would actually move to option number D, which is actually 1,000 milligrams of acetaminophen plus 400 milligrams of ibuprofen, given at one time, is actually equivalent to 5 milligrams of hydrocodone. So this is what emergency rooms are starting to do now, as opposed to trying to give a patient an opioid. They'll actually do 1,000 milligrams of acetaminophen plus 4 milligrams of ibuprofen at one time, again, is equivalent to 5 milligrams of hydrocodone. Then after that, 4 hours later, you can start this alternation of acetaminophen and ibuprofen. Topical NSAIDs, again, the 8 out of 10 pain threshold, not sure it's going to get over that. Topical steroids, they're going to need a steroid in the mix because thermal burns actually penetrate deep. So they're going to need that anti-inflammatory component that's there. But again, I don't know if it's going to get over that 8 out of 10. Someone does a bottle of proparacaine or tetracaine. Again, we don't typically do that just because of the concerns of losing epithelium. Now, who does do that is actually urgent care and emergency rooms. And why they do it is because of this study. Topical tetracaine used for 24 hours is safe and rated highly effective by patients for treatment of pain caused by corneal abrasions, a double-blind randomized clinical trial. Sounds really official. We love double-blind randomized clinical trials until you actually look into the article and realize it's actually a compounded product of tetracaine they're giving. It's not what you get in a bottle. In addition to that, this study's been refuted as well. So you're going to see this still given by urgent care and emergency rooms. You really do need to educate them that this is not a good option for patients. Last summer, we actually removed 2 bottles of tetracaine when it was up in Alaska, given to patients from urgent care. So we really do need to educate them that this is not a great option for patients, that, yeah, they're not going to be in pain, but they also have no epithelium left either. Now, I know you guys just had a kind of an opioid pain lecture, but I quickly want to go through oral analgesics for you, because I do think this is really important for us to address pain in patients, in particular for patients who have corneal ulcers, simplex zoster, post-surgical trauma, thermal burns, and periocular or periorbital infections like a dacryocystitis or preseptal. Patients do not like to be in pain. So obviously we want to make a proper diagnosis first, right? We don't typically like to treat things we don't know what we're prescribing for. Treat the underlying cause for pain if you can. Treat the pain on presentation, don't wait. So we kind of have I guess, kind of a stepwise or a ladder approach. For mild pain, try your over-the-counters. For moderate pain, again, over-the-counters if you can, then your lower dose prescription products. For your severe pain, we're likely talking opioids at that point. But kind of do this methodically. You don't necessarily go to the opioid right off the bat. Patients also want their pain managed over a 24-hour time schedule. They really don't want to be in pain for 8 hours and pain-free for the other time period. So patients want a pain management over a 24-hour time schedule. Mild to moderate pain is often successfully treated with acetaminophen or an NSAIDs. These are our go-to medications, which when people have pains, this is the medications they tend to go to. When we're talking severe pain, so we're ranking now pain 9, 10 out of 10, really your opioids are really kind of your best option for that. But we know that there's potential consequences with it as well, chance for addiction issues and breathing problems, et cetera. So with patients, particularly when we're dealing with patients, we tend to do short-term pain control. We don't do long-term pain control. So if you're going to go into those groups, it tends to be for a day or two before they're moved off to something else. Adjunctive treatments are really valuable for pain management. So doing things like your cycloplegic agents for ocular pain, bandaged contact lenses. We don't pressure patch patients really anymore, but a bandaged contact lens. For potentially creams along that are not obviously onto the eye itself, but for any lesions, say from zoster onto the skin, can also be beneficial for patients. With our systemic NSAIDs, these are great for mild to moderate pain. The additional benefit they have is also reducing systemic inflammation. They're well absorbed from the GI tract. They tend to cross the blood-brain barrier as well. We have to remember drugs that cross the blood-brain barrier are going to start dealing with kind of more of a central pain versus just peripheral pain. They do exhibit what's called a ceiling effect. And the ceiling effect means, if you remember from first year pharmacology, that when you have what's called a dose response curve, right? So increased dose results in an increased response. Well, these aspirin, NSAIDs, acetaminophen have what's called a ceiling effect. In other words, they are particularly given a dose that as soon as you get the dose, they maximize that enzyme that's processing that drug. So they have what's basically effectively called zero order kinetics. They just basically, there's not a dose response curve. They're already at the maximum amount. So anything above that dosing wise, there's no additional benefit to the patient. There's no additional ability for them to, going to use that medication for pain relief. So at that point, it's all toxicity. So there's really important to make sure that the patients, if there's a dosing regimen, that they stay on that dosing regimen, and that, if it's every 4 hours, that they're not taking another dose at 2 hours, because there's no additional benefit to them. All you're getting is toxicity at that point. There's a huge variability that exists amongst your NSAIDs, much like your prostaglandin analogs for glaucoma. I prefer naproxen versus ibuprofen. So little blue pills versus little brown pills. If one NSAID doesn't work, then try another one, because it might. Ibuprofen, by far the most common one we tend to see that patients will have. In the US, the maximum we can get over the counter is 200 milligrams. If you happen to be from Canada, you can actually get 400 and 600 over the counter. Typical dosing is 400 milligrams every 4 to 6 hours. Maximum dose over the counter is 1,200 milligrams. If a patient is on arthritis treatment, they can actually get prescription ibuprofen, which would likely be probably closer to 3,200, but that's prescription dosing, not over the counters. This one is not fun to the kidneys. So if you start getting maximum dosage, so you're getting 1,200 milligrams per day for more than a few weeks, it can actually start interfering with kidney function, can start interfering with blood pressure medications, and particularly your diuretics. So be careful for maximum dosing for more than a few weeks, that if they have any kidney issues, it could actually potentially make them worse. Naproxen, again, the one I prefer. One we tend to think about as Aleve. This is 220 milligram. The nice part about Aleve or naproxen is that it's not only, I think, works better because I think it gets absorbed better, but in addition to that, its dosing's better as well. It's 2 tablets on the first dose and then 1 tablet every 8 to 12 hours. So just less dosing through the day, which I think is always better. And to me, it just works better. I just feel it gets absorbed better into the system. Indomethacin or Indocin, this is a prescription medication. It's not fun for patients. There's a lot of side effects that they can get from it. They can get headaches and all the rest of it. So patients really don't like the side effect profile to indomethacin. Where we see indomethacin used is primarily for systemic inflammatory conditions related to the eye. So something like a scleritis, we might want to prescribe it for. Typically at that point, we're doing 75 milligrams 2 to 3 times a day for it. But there's lots of intolerance to this medication. So long-term wise, patients don't really like to be on this medication. Probably a better option would be ketoprofen. This is indicated for mild to moderate pain, also associated with arthritis, etc. It typically comes in 25 to 50 milligrams every 6 to 8 hours. You may have to go as high as 75 milligrams every 6 to 8 hours, but anything higher than that, again, there's no additional relief to them. So for a patient with scleritis, in particular, if they're having any side effects to the indomethacin, I'd probably recommend ketoprofen instead. They're not likely to have that intolerance that they would have to indomethacin. Your COX-2 inhibitors, we know that one of the side effects to, in particular, prolonged NSAID use is GI issues. Remember, in the inflammatory cascade, there's two pathways. There's a lipo pathway, and then there's a cyclo pathway. Well, steroids intervene actually before both those pathways. So steroids are that shotgun approach. They shut down inflammation because they shut down both pathways of inflammation. With your NSAIDs, they only block the cyclo pathway. And there's two enzymes in the cyclo pathway. There's the COX-1 enzyme, and there's the COX-2 enzyme. The COX-1 enzyme is actually really important for stability of your GI lining. So if you take a something that inhibits that enzyme, that's how you develop gastric and peptic ulcers. By using a COX-2 inhibitor, what you're doing is you're basically blocking the COX-2 one, keeping this COX-1 involved so they don't develop the GI issues that go along with it. Downsides, they can still develop some GI issues, but the big issue was that there was an increased chance for cardiovascular issues with it. So there was increased chance for heart attack and strokes. So there was actually two other products on the market, one called Bextra, the other one called Vioxx, that were pulled from the market because of that. But any prescription NSAID has a big black box warning on them for the potential for cardiovascular complications. Just the COX-2s are more indicated for patients who are taking long-term NSAIDs to prevent the GI issues. So much more likely to see a patient on Celebrex for rheumatoid arthritis or osteoarthritis than being on something like ibuprofen. All right, so you have a 65-year-old patient who suffers from osteoarthritis and has taken an oral NSAID, such as indomethacin, daily for 10 years to help manage their pain. Which of the following is the patient also likely taking? So if you see that they're taking an NSAID, particularly long-term wise, what other medication are they also likely taking in addition to that? All right, let's see what people are thinking here. They're taking omeprazole, right? So again, because it's blocking that COX-1 enzyme, what we want to do is make sure that we're trying to keep the GI lining as stable as possible. So what we can do is basically decrease the amount of gastric juices that are being produced that will eat away that lining. Your proton pump inhibitors are the final step in that production of the gastric juices. There's multiple steps that can activate it. So one of the things you can do is, a histamine blocker. Histamine is one of the pathways that will activate gastric juices. But if you block the histamine receptor, well, then there's still a couple other pathways that can activate the system. Well, the proton pump inhibitor is the final step in the production of the gastric juices. So if you shut that down, you reduce the amount of acid in the stomach. So things like omeprazole, your proton pump inhibitors would be indicated for patients for long-term use of an NSAID to prevent the gastric ulcers that can go along with it. Your contraindications to NSAIDs, again, anyone who has an active peptic ulcer, chronic renal insufficiency, again, because these medications do like to affect the kidneys. Patients at risk are patients who are dehydrated, again, because of kidney issues, and who have hypertension or congestive heart failure. In particular, things like your diuretics and so on. High dose long-term can result in basically impairment of those medications and also increased chance for kidney issues. There's a big black box warning on all your prescription NSAIDs for serious thrombotic events, MI, and stroke. So even though the COX-2 inhibitors get the kind of the bad rap for them, all your prescription NSAIDs have that warning on them. Again, adding omeprazole or a proton pump inhibitor to patients who have long-term NSAID use can be beneficial for them. The addition of that proton pump inhibitor, they found even with patients taking their NSAID, continuing to take their NSAID, that 80% of them resolved even though they continued to take the NSAID. Probably wouldn't recommend that, but ultimately it's probably the best option if patients are going to be on them long-term. All right. Which of the following is not a characteristic of acetaminophen? So when we think about acetaminophen, which of these ones is not typically associated with it? All right, let's see what you said. So remember, for acetaminophen, it's good for pain, good for fever, has no effect on inflammation. So it is actually good for conditions that have bleeding, such as a hyphema. You wouldn't want to give a patient who's had a hyphema an NSAID or aspirin, because it's going to thin the blood out even further and potentially increase bleeding. So acetaminophen would actually be a good option for them. With acetaminophen, it's not really well understood how its pain relief happens, but it's thought to more affect the central nervous system versus the peripheral, which is what the NSAIDs primarily affect. Again, good for mild to moderate pain. Take-home message, good for pain, good for fever, has no effect on inflammation. Again, if a patient has a hyphema and there's some eye pain or pain associated with it, then acetaminophen would actually be a good option for them. It comes in multiple different doses. This regular strength is 325. There's an extra strength, which is 500. There's also an extended release, which is 650. The original dosing, max dosing in the day was 4,000 milligrams or 4 grams. It's been dropped to closer down to 3 to 3.2 because of concerns of liver issues. If you're prescribing a prescription kind of that has acetaminophen in it, then likely the patient's also taking something over the counter or something else as well. So the concern is once you get over 3, that can result in liver damage. It also has a ceiling effect like NSAIDs and aspirin. The most common cause for acute liver failure in the US is acetaminophen overdosing. And there's multiple different products that have acetaminophen in it. So they could be actually just taking acetaminophen, but then they take Tylenol PM to help them go to sleep. Well, that has acetaminophen in it. Midol Complete does, NyQuil does. So all these medications, all these products have acetaminophen in it. It's very easy for them to overdose on it. Again, liver damage is the biggest concern, in particular patients who already have any liver issues or they have chronic alcohol, then that dosing is probably even lower than that. Our typical alternation, which works really well for pain management, is alternating your 2x325s of acetaminophen, followed by 2 hours later of 2 by 200s of ibuprofen. Now you can do them at one time. The downside to that is that they both have a time period of 4 hours. So at that point, they have to wait 4 hours before they can take their next set of meds. And that's a long time to wait when patients are in pain. In addition to that, their pain meds are starting to wear off at that 4-hour time period. So it's better to do it every 2 hours because there's always some pain relief on board. And also they're only having to wait 2 hours before they take pain meds again. So I would recommend them every 2 hours. Again, for your acetaminophen, its typical dosing or standard has been 4 grams per day. It's now probably closer down to 3 to 3.2. With ibuprofen, it's 1,200 over the counter, 3,200 if it's going up into prescription dosing. Gabapentin, this is actually classified as an anticonvulsant drug using for patients who have epilepsy, but has also been studied for patients who have chronic neuropathic pain, in addition to, or in particular, patients who have postherpetic neuralgia and diabetic neuropathy. And all other types of pain, it hasn't really been established for, hasn't been clinically trialed for most other types of pain. For that chronic neuropathic pain, it's been shown to be really effective for that. We are seeing a lot of patients being moved to gabapentin to try to get away from the opioids. And the downside is it's not always really effective in those patients because it's really not good for that kind of acute pain. It's more for the chronic neuropathic pain. So I don't think we should necessarily be moving everybody to gabapentin because I don't necessarily think it works for every patient. I had an example of a patient who had really painful recurrent corneal erosion. She was referred to me in for an amniotic membrane. When she came in, she was going, I was given gabapentin to help my corneal pain and it's just not doing anything for me. I gave her Tylenol 3, which did. So I think for certain pains, it just doesn't really work for. With gabapentin, it's typically a titrated up dose, which means that you don't ever give them the full dose at one time, which you do for other meds. In this case, you have to titer up on it. It has too many side effects if you just do it as a full dose. It comes in 100 milligrams and 300 milligram capsules. You're typically doing 300 milligram dosing. And so it's 300 milligrams for the first day, 600 for the next, then 900, then 1200, and then 15 and 18. So you titer up to where you get that pain relief that you need. It also has a strong sedative effect. So the first time the patient takes it, they really shouldn't be during the day because it'll make them really dopey. So really want to do it at nighttime to kind of get around that side effect profile, and just tell them to be cautious because it can actually make them quite sedated. So these are the couple studies that showed that 1,000 milligrams of acetaminophen plus 400 milligrams of ibuprofen at one time is actually equivalent to 5 milligrams of hydrocodone. Now that's just based strictly on pain levels. In other words, if we're ranking pain, they're equivalent. If you're asking patients which one they prefer, they always prefer the opioid. And why? It's because the opioid bypasses the normal pain pathway. It makes them not care about the pain. So there's actually kind of an emotional component that goes along with your opioids. They're just going, oh, just no pain, I don't care about it. That doesn't solve the pain, just makes them not care about the pain. Where you're not going to get that same kind of emotional component, what it goes along with the ibuprofen and acetaminophen. But pain relief is equivalent between the two. So to try to get away from the opioids again and that whole addiction issue is that acetaminophen, 1,000 milligrams, 400 milligrams of ibuprofen at one time is, I think, a really good option for patients who are in severe pain. Then 4 hours later, they can start the alternation of the 2x325s and then the 2x200s. All right, which of the following group of medications when combined with an opioid is one of the leading causes of death in patients? All right, let's see what you thought. And it's actually the benzodiazepines. So with your benzodiazepines, they are actually sedative medications. So they'll put people to sleep. I had surgery in 2018. When I came out of surgery, the nurse asked me how I was feeling. I go, I hurt. So she said, rank my pain. I said 8 out of 10. Well, because I was hooked up to an IV, they gave me morphine. Well, morphine took care of my pain because it stopped my breathing. If you're not breathing, you tend not to be in much pain. Because I was still coming out of sedation, if you go to sleep, then the opioids can actually shut down your automatic breathing centers. So that's the trade-off. You get great pain relief, but it also can potentially result in significant breathing issues in patients. So we have to be careful about that. So the benzodiazepines in combination with the opioids is a potential leading cause of death, and mainly because the benzodiazepines are a sedative medication. They're going to basically make patients sleepy. With anytime you prescribe an opioid, you're going to want to make sure you go to a PDMP, which is the drug monitoring program. And so I can prescribe opioids here in Oregon, but also plus in Alaska as well. If I'm ever to prescribe one, I have to go to the PDMP. And the PDMP with the drug monitoring program not only is to see if they're taking any other opioids, but it's also to see if they're taking any benzodiazepines as well. So they're looking for that combination of medications. And when you go into the PDMP, you not only have to look for their name. So say their name is Nathan. You also want to look for Nate because you want to see if they're getting medications from other places. But the other one that they want to check is the benzodiazepines because of the fact that they're sedative and that puts patients to sleep. And when they go to sleep, then the opioid kicks in and they potentially just don't wake up again. The CNS side effects to your opioids, there is some dizziness, lightheadedness, sedation, drowsiness are the most common. The euphoria that they get is typically not by swallowing pills. When you think about patients who abuse opioids, they're not swallowing pills. They are snorting them or injecting them because they want 100% bioavailability in the system. They want the full wallop of the drug. Most times, these ones are kind of make you really kind of dopey. The ones that patients are abusing, they're getting them into their system to get the maximum effect of it. So they're typically bypassing that liver system that's there. The most serious side effect is the respiratory stuff, which basically can make them not wake up again. What's interesting is in 2024 was the first time we've actually saw a reduction in opioid deaths. And since the time they're kind of in the 90s, we've just seen this increase in opioid deaths over time. Well, that was the first time there was actually seen to be a drop. And why they think is because of kind of two things. A lot of the fentanyl was taken off the streets. In addition to that, Narcan became available over the counter. And I know Tracy was talking about the use of Narcan and how she carries 3 doses with her. It is important that people who are abusing opioids also are carrying it with them as well. So that's a readily available source for patients. So ultimately, that's where they're thinking is the combination of not only taking fentanyl off the street, but also potentially the fact that Narcan is more available. You want to make sure that you're avoiding any other depressants, so particularly not using things like alcohol. There's the list of your scheduled medications, pain relief wise. Remember, scheduled medications require that you have a DEA number, and they go 1 through 5. There's really not anything commercially available in your Schedule 1s. Schedule 5s have the least addiction issue. So that's going to be your cough medicine with codeine. Schedule 4s are tramadol. Schedule 3 is things like Tylenol 3 and Tylenol 4. I do understand we really don't have those products anymore, but everybody knows what we talk about when we're Tylenol 3 and 4. If you're going to codeine in and of itself, it's actually a Schedule 2 medication. And in that is also oxycodone and hydrocodone. They used to be Schedule 3 medications, and they were moved to Schedule 2. So if you have the ability to prescribe them, typically it's because you've been grandfathered in, not because you actually have the ability to prescribe Schedule 2 medications. I don't think any of us can really prescribe Dilaudid or Demerol. It's because you can prescribe oxycodone and hydrocodone. It's because you've been grandfathered in when they were Schedule 3s. Again, there's no really Tylenol 3 and 4s any longer, but this is a mainstay pain relief. This is your acetaminophen plus your codeine. In the States, we have Tylenol 3s, which are 30 milligrams of codeine plus your acetaminophen. It's 1 to 2 tablets every 4 hours. It does have the ability to actually make you sleepy as well, so make sure patients understand that. Hydrocodone, but 6 times more potent than codeine. There's all your different products that have hydrocodone. They come in 5, 7.5, and 10, with or without potentially acetaminophen or ibuprofen. With your oxycodone, this is the street drug that people want. It's 10 times, 12 times more potent than codeine. It's almost comparable to actually getting morphine. This has the highly addictive properties to it. There's all the different products that have oxycodone in it. It comes in 2.5, 5, 7.5, or 10. And you can get it with acetaminophen in the US. You can't get it with ibuprofen or aspirin any longer. I know there was talk about tramadol and not really being effective. And I'm not sure I'm going to agree with that. I do think tramadol has an effect, but I agree with Tracy when she said is that it's very patient dependent. I have patients that take tramadol and swear by the tramadol that it works. Is it placebo? Who cares? It works for them. But I do think it's a very hit or miss medication in patients. It is actually a synthetic analog of codeine, so it doesn't have the full effect of codeine. And there is a, supposedly less chance for addiction issues, but they are still possible. So I would think that potentially if you have a patient that has pain, I potentially would try tramadol and see if it works for them. Tramadol is one of the #1 pain meds that's used in places like Australia. So they don't typically use the other ones. They use tramadol as their mainstay. So I think it's a very hit or miss medication on patients. I've used tramadol and I found it was effective for me. It does have a bit of a sedative effect as well. So I'm not sure that I necessarily totally agree with that study. I'm saying that it's basically no better than placebo because I do think it works for certain patients. It comes in an extended release formulation, and it also comes in combination with acetaminophen as well. All right, so that's a quick review over your pain meds. All right, let's change gears here. 13-year-old female patient presents with acute onset swollen and painful lower lid. EOMs are full, though there's some discomfort and eye movement. Pupils are normal. Patient has low-grade, well, that's not actually a low-grade fever. 100 degrees centigrade isn't a low-grade fever. Meant to be 100 degrees Fahrenheit. 38 degrees centigrade. So other than your patient spontaneously combusting, what is this? All right, let's see what you said. And majority going with this being a preseptal. Some saying this is an orbital and also a dacryoadenitis. If we're talking about internal hordeolum, they typically don't have low-grade fevers. They don't typically have that kind of swelling that goes along with it. Orbital cellulitis, I might have caught you on the orbital cellulitis by the temperature. The crucial cutoff is actually 102 degrees Fahrenheit. That separates out an orbital from a preseptal cellulitis. In addition to that, your orbital cellulitis patients are sick patients. They're going to have decreased vision. They're going to have an APD. They're going to have proptosis. They're going to actually have restricted and painful eye movement. So they are different. Dacryoadenitis is our infection of the lacrimal gland, which would be superior and not inferior. Now, what I would like you to compare this to is actually a dacryocystitis. This could be confused as dacryocystitis. Now, maybe not because it extends so far down into the cheek, but if you've got this inflammation just in his kind of canthal area, then the difference would actually be, is this preseptal or a dacryocystitis? Now, the treatment for those two is exactly the same. However, after that, you actually need to send him to oculoplastics because with a dacryocystitis, you've got an infection of that lacrimal system. There's potentially a blockage in that system. You do your oral antibiotics to take care of the infection, but you haven't taken care of the blockage in the system. And with that infection inflammation, you actually get a kind of a narrowing of the canaliculus, and ultimately they're likely going to block off at some point anyway. So to diagnose it, you press on it, pus comes out of the punctum, then it's a dacryocystitis. Are they going to be happy you did that to them? No, it's going to hurt. But if you had pus come out of the puncta, it is actually a dacryocystitis. And you need to know that because once you treat them with the oral antibiotics, send them to oculoplastics. And what they're going to do is actually run a silicone tube through the system. They run it through the upper and lower puncta and make basically a loop, and then they tie off that loop. There's a knot in there. And basically what it's going to do is scar open that system. Now, please educate your patients that if you're sending them off, say for epiphora, and they put a silicone tube in, they're going to be still epiphora because that tube is not draining the system. It's actually scarring the system open. And they need to keep it in there for about 3 months. And then what they do is they snip off the end and they pull it through. I had a patient up in Alaska that had bad epiphora. I recommended one of our surgeons here in Portland. So she came and saw Dr. Sullivan here. And I actually happened to see her up in Alaska because she actually accidentally grabbed that silicone tube and she kind of yanked it. So she had this big kind of loop of silicone tube hanging out. So I talked to Dr. Sullivan. He said, just snip it and you grab it with some forceps and then have to yank really hard to get the knot through. But that system is designed to scar the system open. And that means that they don't have to have a DCR done, which is where they have to cut through the bone and actually put a tube in. So they'll actually run a silicone tube, keep it in there for a couple months to scar the system, and then hopefully the system stays open. There's your differences between orbital and preseptals. Again, patients with orbital cellulitis are going to have decreased vision, proptosis, there's going to be an APD, temperature typically 102 to 104. All right. We've now determined our 13-year-old's preseptal is actually secondary to our MRSA infection. Which of the following should you prescribe? Patient has no known drug allergies. Now, typically we're going to diagnose MRSA because we've sent something off for testing. However, there's probably 5 different scenarios where you could potentially already automatically start thinking MRSA without waiting for testing to come back. If patients had a MRSA infection previously, they always have MRSA. So that goes up on your suspicion list. Your patient is in a hospital, assisted living place where there's lots of people around. The infection exceeds the presentation. In other words, you're seeing a patient come in and first of all, say your thing is hordeolum, but it's up closer to where their brow is, or their pain exceeds what the presentation looks like. So they're coming in, they're saying it's extreme pain. Your patient has already been treated with, say, something like Augmentin or something, and, it didn't work for them. Or, what's the other one? Healthcare professionals. So healthcare professionals, we'd be much more concerned that it's also MRSA related as well. All right. So in this case, you want to use Bactrim or Septra. Kind of give you an answer that if Augmentin doesn't work, then you start thinking MRSA. So methicillin-resistant staph, really anything in the penicillin group is not going to work for you. So Augmentin is amoxicillin, not going to work. Keflex, part of the penicillin family, also not going to work. Really don't like to see Cipro here at all. Cipro, first of all, is not active against MRSA, and there's really no indication in optometry for us to ever use an oral fluoroquinolone. They're actually way too toxic to the system. The FDA's basically come out and said, even if you think an oral fluoroquinolone is the best option for you, find something else to use. They've been finding patients developing rupturing of tendons. They're developing neurological problems, developing migraine headaches, seizures, changes in blood sugar levels. Really, anything you can think of can happen with the oral fluoroquinolones. Topical-wise, perfectly fine. Oral-wise, there's no indication in optometry ever to use them. Unless the patient's got cat scratch disease or potentially toxoplasmosis, there's really no indication for us to use them. So in this case, Bactrim would be the correct answer. Now, remember, Bactrim has actually got a combination of sulfamexazole and trimethoprim. So this is a sulfa-based medication. So if a patient has a sulfa allergy, not something you're going to want to use. So the other two options for patients with MRSA are actually clindamycin and doxy or minocycline. It used to be that doxy and minocycline were considered treatments for MRSA if they were already tested and found out to be, that the strain was susceptible to doxy. But because of the side effects of Bactrim, which is a sulfa component to it, and clindamycin, which can result in pseudomembranous colitis, and upwards of 10% of patients will have actually pseudomembranous colitis from clindamycin. So 1 in 10 will potentially have a condition which could kill them. Those aren't great odds for me, so not something that I would probably recommend. So to get around those patients that have much more side effect profile, doxy and minocycline have been moved actually up as first-line therapies for patients with MRSA skin infections. My go-to for a patient who I don't suspect for MRSA would be Augmentin. That's, remember, amoxicillin plus clavinic acid. I think it just works really well for patients. You're going to see here the Augmentin 5 milligrams TID or 875 BID for 5 to 7 days. Remember, patients over the age of 12 are based as adults for their dosing. And for adult dosing now, there's no longer more than 7 days for an antibiotic prescription. Why? It's because if you haven't taken care of that infection in 7 days, you need to switch them to something else. Do not renew antibiotic prescriptions. So don't have them come back in 7 days and say, oh, I'm going to give you Augmentin again, because you're going to develop resistance that way. Switch them to something else. Switch them to Ciclor or Omnicef or some other medication, so that you can kill the bugs that are there and you don't develop resistance to the original one. Now, it's thought that kids should still be in the 10 to 14 day range, and recent evidence shows that they probably should be on the same day, 7-day schedule as well. If you haven't taken care of the infection in 7 days, switch them to something else. So Augmentin is amoxicillin plus the clavinic acid. Remember, this is a beta-lactam antibiotic. So the beta-lactam antibiotics have a beta-lactam ring that sits up here. Well, that beta-lactam ring is the active component to that antibiotic. Well, staph is really smart. It produces penicillinase, which cleaves off the beta-lactam ring and inactivates the antibiotic. So for antibiotics for bugs to develop resistance, there's really kind of 3 main ways. You either break down the antibiotic, you prevent it from getting into the cell, so you change the receptor sites, or they take it in and they turn around and pump it right back out. So in this case, they're doing an enzymatic process. They're producing penicillinase to inactivate the antibiotic. Well, the clavinic acid is an enzyme that counteracts that enzyme. So in other words, it has no antimicrobial properties to it. It is just an enzyme to shut down the penicillinase activity. So Augmentin is great for any soft tissue stuff. So dacryocystitis cystitis is internal hordeola preseptals. You're going to see internal hordeola there. And we see a lot of patients who come in with internal hordeola or styes. An internal hordeolum is basically classified as a low-grade preseptal cellulitis. So I can imagine any of you treating a preseptal cellulitis with a topical. For me, and because I have a lumps and bumps clinic and I see a lot of patients coming in with hordeola and chalasia, et cetera, that internal hordeola, I go to an oral because it's classified as a low-grade preseptal. The biggest issue that comes with Augmentin is because it's amoxicillin, is the antibiotic-associated diarrhea. And whenever you take an antibiotic into your system, they are basically indiscriminate killers. They're going to kill not only the bugs that are in your lid, but also in your gut. So you can change the flora that's there, which can result in issues with GI issues, so nausea, diarrhea, et cetera. Amoxicillin is a big player in that one. It's probably one of the biggest players in that one. So it's really important that if patients are taking, in particular Augmentin, but really any antibiotic, that 2 hours after they take the antibiotic, they do some type of probiotic. And that can be a container of yogurt. They don't do dairy. They can do whatever other probiotic they want. But this is really going to be beneficial for their gut. But don't obviously take it at the same time, because that antibiotic will kill the probiotics that are there, but 2 hours after. And I tell patients, when you get your prescription from the pharmacy, grab a container of yogurts, so little containers of yogurt, and 2 hours after, have that. And that will definitely help improve their gut issues, less chance for nausea, diarrhea. Now, what percent of the population has a true penicillin allergy? So I'm asking if they have a true penicillin allergy, not the percent of patients who actually believe they have a penicillin allergy. Those are two different things. All right, let's see what you said. And the correct answer is actually 1%. 1% of the population has a true penicillin allergy. The percent that actually believes they have a penicillin allergy is about 10%. And they actually could have had a penicillin allergy as a kid. That's when most people find out they have a penicillin allergy as a kid. But after 10 years, 80% of those patients actually outgrow their penicillin allergy. So they lose that penicillin allergy. So if you had a penicillin allergy when you were 5, by the time you're 20, you've outgrown that penicillin allergy. In addition to that, patients who have penicillin allergies often confuse them with the side effects of medications, not actually having a true penicillin allergy. So the recommendation from all healthcare professionals is that if a patient comes in, reports they have a penicillin allergy, that you highly recommend that they get the skin testing done to confirm that they actually have a true penicillin allergy. So what they'll do is a kind of a two-step process. They'll go in and get the skin test done. If there's a reaction on their skin, they actually are going to be what's called direct challenge. It's going to be put into liquid form. They're obviously taking all the precautions to prevent an anaphylactic shock or so on. And they actually drink a solution of penicillin. They don't react to that. They actually drink a preparation of cephalosporin, which could potentially cross-react with them. And at that point, then they can be taken off of having the penicillin allergy. And it's been found that patients who say they have a penicillin allergy, say have a skin infection, they're actually treated with other medications that are usually less effective than the penicillin, which typically means a prolonged course of the condition, in addition to that, increased health costs. So please recommend your patients who say they have a penicillin allergy to actually get the penicillin testing done. So Augmentin, my go-to, again, 250, 500, and 875. I'm exclusively 875 in patients unless they can't swallow the pill. 875 are pretty big pills, so make sure you want to swallow them. There is actually 1,000 milligram extended release. We don't really use it much in the US. It's used much more in Europe and other places. You can't use it in patients under the age of 16. It's just not one we commonly use, but usually 875 twice a day. Your cephalosporins, very closely related to, they're part of the penicillin family. They're a beta-lactam antibiotic, so have the same mode of action, same resistance issues. They come in 5 different generations now. As you go up in generation, you go up in gram-negative coverage, but you also typically go up a significant increase in cost as well. It's poor orally absorbed. In other words, there's not a lot of medications in this group that are orally absorbed. Most of them are IV or IM. The big ones you want to remember are Keflex, Ciclor, and Omnicef. Now, Omnicef is no longer available as a brand name off Omnicef. It's Ceftonir. And you can get that as a generic. And I really like the Ceftonir. I'll tell you about that in just a sec, why I like it. But Keflex is probably the one you're most familiar with. It's actually a first generation. If a patient has a potential penicillin allergy, then don't use a first gen cephalosporin. Don't use Keflex, because that's the one that's most likely going to cross-react with the penicillin allergy. Use Ciclor or Omnicef. Second and thirds, not likely you're going to cross-react with someone who has a penicillin allergy. So again, Keflex, probably the more one that you're most familiar with. I'm not necessarily a huge fan of Keflex, not because I don't think it works, it's because of its dosing. It's 500 milligrams 4 times a day. It's important that it's 500 milligrams 4 times a day. You'll see if you go back to really old Will's eye manuals and so on, they'll say, well, if you have someone who has a hordeolum, you can use Keflex 2 or 3 times a day. You don't see that in newer prints because its dosing is 500 milligrams 4 times a day. By decreasing that dosing, you're increasing chance for resistance issues. So my issue with this is that people prescribe it and they don't prescribe it the way it should be prescribed. In addition to that, it's 4 times a day dosing. So it's just more dosing than, say, Augmentin twice a day. I do like C-chlor. I think C-chlor actually works really well. There's a lot less GI issues that you're going to get with C-chlor than you potentially get with Augmentin. It's 250 to 5 milligrams every 8 hours, so 3 times a day. And then I mentioned before that Omniceftin is no longer available in the US as a brand name, but it is available as a generic. So Ceftonir is available. It comes in 300 milligram capsules, and it's recommended as twice a day dosing. But this is one of the few medications, antibiotics, you actually can take both of them at the same time, and it's equally as effective as if you do it BID dosing. Still recommended to do it twice a day dosing, but if patients have a hard time remembering to take medications, they can take this at one time, and it's equivalent to taking it twice a day, which I do like as a dosing for certain patients. The last one in the group is Bactrim or Septra. And again, remember, this is a sulfa medication. So if a patient has a sulfa allergy, then they can't take this. It's a combination of sulfamethoxazole plus then the trimethoprim. They have a synergistic ability to work together to make it better than either of those individual medications on their own. It's used for a lot of times chronic infections, so urinary tract infections, prostatitis, and so on, where it needs to take time to get into those systems. It comes in 2 strengths. It comes in standard strength, which is actually 2 pills every 12 hours. And it comes in double strength, which is 1 pill every 12 hours. Now, if you're reviewing your patient's medication list, which of the following medications would be contraindicated to giving a patient Bactrim or Septra? So you're reviewing your patient's med list, and you see one of these medications on it. Which one of these medications would be contraindicated giving Bactrim to? Because the potential is you could actually kill the patient. All right, let's see what you guys are thinking. And the correct answer in this case is actually methotrexate. And why methotrexate is because the sulfa medications work by what's called folic acid inhibition. They inhibit folic acid, so bacteria need folic acid to replicate. Well, methotrexate is also a folic acid inhibitor, which is why if you see a patient who has rheumatoid arthritis, they're taking methotrexate, they're always taking folate or folic acid with it. If they don't, they develop mouth ulcers and the rest of it. If you inhibit folic acid to a certain degree, you can actually result in bone marrow suppression. So you don't want 2 medications that are actually suppressing folic acid. So you're going to get a big warning on it. If your patient is taking methotrexate, they can't take Bactrim or Septra with it. In addition to that, this medication can result in kidney stones. So we want to make sure they're drinking plenty of fluids with it. In addition to that, it's also a sun sensitizer, much like Doxy is. So we want to make sure that they're taking some type of sun protection, which is often overlooked when these patients are talked about these medications, the lots of fluids, in addition to that, to make sure that they are taking sun protection. There's your treatments for MRSA. So again, Doxy, minocycline are in there, clindamycin, plus your Bactrim or Septra. All right, we'll switch gears here a little bit. You can see on the bottom, this is a case by Dr. Tammy Thon, who's a really good friend of mine. We did a lecture together at Academy a few years ago, and we lectured it basically as facts or fiction. And with that, we kind of looked at different conditions, and we kind of went to the literature and said, what's the best way to treat these conditions? So this is one of the cases that Tammy had. This is a 67-year-old female patient. Tammy was working at the VA at that time, came in just basically for a routine eye exam, complained, had no complaints, eye exam was fine, came back 2 days later complaining about the fact that she had developed headaches and she had vision loss. Her ocular history was unremarkable. Again, her last eye exam was 3 days previously. Her medical history is unremarkable as well. I think you would agree that she's got some visual field loss, right? She's got a homogeneous hemianopsia. Where's the problem? Well, there's your problem. So the patient's had an occipital lobe ischemic stroke. So in addition to doing the visual field, what's your management for this patient? All right, that's what you said. In this case, it's actually the correct answer is minocycline. And I know most people went with baby aspirin, but in this case, minocycline. And we're going, well, why are we giving an antibiotic to a person who's had a stroke? Well, your tetracyclines have actually strong anti-inflammatory properties to them. And in particular, it's minocycline, not doxy, because doxy does not cross the blood-brain barrier. Minocycline does. Minocycline, we don't tend to prescribe an awful lot because they get patients with a lot of vestibular side effects because it is crossing the blood-brain barrier. So let's go to, I have a question before we move on. Which of the following statements is incorrect with respect to the tetracycline group of antibiotics? So when you think about the tetracyclines, which of these statements is incorrect? All right, let's see what you thought. So everybody chose the last one as the incorrect statement. And actually the incorrect statement is it does nothing to blood sugar levels. So it's not going to change those. That final statement is actually a correct statement. There's evidence to show now that with doxycycline in kids, as long as they're using it less than 21 days, you can use it regardless of age, as long as it's less than 21 days. So it does not apply to minocycline or tetracycline, but it does apply to doxy. Traditionally, doxy has been reserved for tick-borne diseases in kids. It's not going to cause discoloration of teeth. Dentistry's known this for probably 30 years, just never told anyone else about it. Why minocycline in the patients who've had a stroke? Because it actually lowers MMP9s. So they're very powerful anti-inflammatory agents. They reduce microglial activation, and think about that as basically scarring in the system. So they're reducing scarring in the system. They're a nitric oxide producer, which is a free radical scavenger, which again decreases damage. But the most important component that minocycline has is what's called, it inhibits apoptic cell death. And apoptic cell death is basically programmed cell death. So you traumatize a cell, and then instead of fighting for its life, it just kind of wants to die. And that's what happens when you have a stroke. You have an acute ischemic event. Not all the cells die at one time, but some of them are traumatized. Well, instead of those cells trying to fight for their life, they actually just go through this programmed cell death. Well, if you can prevent that, then you can prevent further damage in the system. So most of the literature comes from neurology, and I'm going to show you a couple studies here. This first one is probably the bigger of the studies that I'll talk about, but it was patients who had an acute ischemic stroke presented to the emergency room or urgent care within 24 to 48 hours. That time they were put on minocycline, 200 milligrams 200 milligrams a day for 5 days. So it's either 100 milligrams at twice at one time, or BID, but 200 milligrams per day for 5 days. Then they were scaled on the NIH stroke scale, which is that thing that you see on the right. So if the patient's level of consciousness, their facial palsy, etc. Increase in score means an increased severity of the stroke. 0 to 1 was completely or nearly completely improved. 2 to 7 was mild. 8 to 14 was moderate. Greater than 15 was considered severe. All right, so there's actually 3 studies here. The one we're talking about right now is this top one. So patients started at 7.5 in the minocycline group, 7.6 in the control group, so effectively into the moderate category. Given 200 milligrams of minocycline for 5 days, assessed at day 7, 30, and 90. You can see at day 90, their score had dropped down to 1.6, almost completely resolved, versus the control group, which is 6.5. The second group started up at 2.8, 2.0 in the control group, ended up at 0.9, and then stayed at basically 2.1 in the control group. The final study was actually higher numbers are better in this case, started off at 70 and 64, ended up at 95 and 78. So we can see here that there was actually improvement in those patients with a stroke. Now, I can't tell you what specific parameters there were, but their overall score was improved. So what? Well, there's one case report in the literature, and this was by 2 optometrists who had a patient who had an ischemic stroke, and you can see that he's got a significant visual field defect. This this is 3 weeks post-stroke. He was watching some TV program and saw this use of minocycline in stroke patients. So he contacted his optometrist and said, I want to try this minocycline and see if this can improve my visual field defect. So again, giving him 100 milligrams of minocycline twice a day for 5 days. Then here's him shortly after the stroke, or sorry, after the treatment. Here's him a year later. Now, can I prove that the minocycline did this? Nope, I can't. But I've given this lecture quite a few times, and I've got a folder of probably about 15 different cases where doctors have sent me pre and post visual fields from patients treated with minocycline to find that there's been an improvement in visual field. Now, why is this really important is because, particularly in Oregon here, this person doesn't have a driver's license. This one does, right? So in Oregon, I need 110 degrees of continuous visual field to have a driver's license. So he effectively still has a driver's license. So questions that you want to ask about this. What's the dosing again? 200 milligrams of minocycline for 5 days. What time period do you want to start it? Well, as close to the stroke as possible, but I think you need to probably be within the first month. I do have a case report of an optometrist telling me that she saw improvement in a patient 6 months post-stroke. I think you're really pushing it at that point. So probably within the first month if you can. I've been asked, can you repeat it? Well, again, there's no evidence to show that this is actually really effective. So repeating it, we just don't have any information on that one. I will tell you that all the patients that were enrolled in this study, not one patient got worse. So remember, you're dealing with potential benefit versus risk. Side effect profile for minocycline, pretty much minimal. They might have vestibular side effects, but unless they're allergic to minocycline, they're only on it for 5 days. So your risk benefit is that no risk for a potential benefit. Now, I'll tell you that I wouldn't promise them anything. I wouldn't tell them and say, we're going to show an improvement in visual field. I would say, let's try this. There's really no side effects to it. And let's try it to see if we can improve your visual field. Why not a longer dosing is because it really has a long half-life in the system. It's probably lasts, probably 100 hours in the system. So and remember, we're dealing with anti-inflammatories, not antimicrobial properties. So it stays in the system actually for quite a long period of time as an anti-inflammatory. The only other condition that I would suspect it might work for, and this is just me personally and me kind of just thinking on the outside box, would be an ischemic optic neuropathy. And why is because I think they have the same process involved. I think it's an acute ischemic event, and I think that potentially it could be helpful for those patients as well. All right, with your tetracyclines in the US, we have doxy as 20, 40, 50, and 100. Your do's and don'ts for doxy, make sure that you don't take it before going to bed. Avoid calcium and antacids. Avoid dairy. The other one is actually avoid magnesium as well because it decreases absorption. Absolutely take doxy with food because if not, it tears up your stomach. And then make sure that your patients are educated about sun protection because it is a sun sensitizer. So this is the studies that showed that basically we've been always discouraged to use tetracyclines under the age of 8. Recommendations have changed stating doxy, but no other tetracycline can be used for short courses, less than 21 days, regardless of age. So I'm not saying willy-nilly start prescribing 6-year-olds doxy, but if you do feel it's going to be a benefit for them, then I would recommend you can do it as long as it's less than 21 days. It is indicated for MRSA. And the one that we've traditionally in the eye care thought about using doxy for is for MGD. I have not used doxy for MGD in a really, really long time. First of all, I don't necessarily think it works all that well. And there's much better ways to treat MGD. And again, in my lumps and bumps clinic, I have patients who come in, blepharitis on a scale of 1 through 4, like 150. So I actually use a pulse dose of azithromycin instead. And there's been actually several studies to show that azithromycin is better than doxy in treating MGD. The first one was the single Z-Pack was better than actually a 30-day treatment of doxy. Second one was we actually did an alternation, like we did 500 milligrams for 3 days, then off for 4. The one I use now is actually the most recent study is actually a single gram dose of azithromycin given once a week for 3 weeks is equivalent to a 6-week course of doxycycline without the GI side effects, without the sun sensitivity issues. So you do a 1 gram on a Monday, 1 gram the next Monday, and 1 gram the following Monday. It's actually hard to get 1 gram single doses. So I'd recommend 500 milligrams, prescribe 6 of them, and then tell the patient you're going to take 2 this day, 2 the next week, 2 the following week. The pharmacist is going to tell them they're going to take 1 pill for the next 6 days in a row. Make sure your patient understands that that's not what they're doing, right? 2 pills, following week, 2 pills, third week, 2 pills. And then you're going to bring them back in a month. And at that time, you're going to actually express their glands. And you're going to see that the glands have actually changed. But if they're plugged, you need to actually squeeze all that crap out first to allow the new stuff to come out. And I've done this several times for patients, and where they came in, their glands are capped and so on, and you can squeeze nothing out. They come back a month later, you can just go right across without any heat and just squeeze them all across. So I think that's a much better option than Doxy for MGD. All right, I'm kind of running short a bit of time here. So I'm going to kind of quickly go through the herpetic stuff. This is zoster. Remember we talked about zoster dosing for treatment. I would go valacyclovir 1 gram 3 times a day, but you could do 800 milligrams 5 times a day, or famciclovir, which would be 500 milligrams 3 times a day. All right, so remember this is actually the chickenpox virus, the varicella virus. If you're in my age range, you had the natural wild type. If you're younger than me, then you're likely been vaccinated for it. 96% of people develop it by 20 years of age. Vaccines also now available. The reactivation is the zoster or shingles, so depending on where on the body it shows up. Originally, we thought that if it was basically a person of older age or immunocompromised. So it used to be if you were 60 and younger and you had zoster show up, you needed to be worked up for it. Then it dropped down to 40 and less. Now it dropped down to 30 and less. Pretty much if you develop shingles or zoster, unless you're probably a teenager or a child, you're not likely going to be worked up for it, because the new demographic for zoster and shingles is really 20 and 30-year-olds, where it used to be before that was not, but now it is. And we can see here that the rates in adults 30 and older, there's actually a significant decrease over time of what we're seeing, that peak incidence of people developing it. Now, the big concern is actually the post-herpetic neuralgia, the PHN, and that is still patients who are older. So if you have, I had mine as soon as I actually turned 40, I had my T3, T4 involvement. My chance of developing post-herpetic neuralgia was pretty low. The older you get, much greater chance. But the age range of we're seeing patients who are developing shingles and zoster is dropping dramatically. Symptoms, patients typically feel a malaise or a tingling sensation, probably before the lesions show up. Once the lesions show up, then they start to break, and that's when they get really painful. They tend to follow a dermatome, so it's going to be that vertical line is going to keep that vertical midline involvement. They develop their vesicles, crusting, Hutchinson sign. Typically, we think about Hutchinson sign as the lesion to the tip of the nose, and it doesn't have to go to the tip of the nose. Any nose involvement is actually an indication of a Hutchinson sign. So rash on the side or the tip of the nose increases the chance for ocular involvement. With the ocular involvement, the most common manifestation is actually an anterior uveitis. So if you see any lesions on the nose, go looking for an anterior chamber reaction, because that's likely what you're missing. We know that associated factors increasing age, immune deficiency, increases those chances of reactivation. It dramatically increases over the age of 50. Skip that over that question. Again, remember our dosing, 800 milligrams 5 times a day, valacyclovir or Valtrex 1 gram 3 times a day, and then famciclovir 5 milligrams 3 times a day. It's best started within the first 72 hours, but even if they don't get into you by the first 72 hours, you're still kind of indicated to go through the treatment regimen. It decreases the number of crops of lesions that they're going to have and decreases the intensity of that outbreak that's there. Pain management wise, interesting enough, tricyclic antidepressants, something like Elavil, is indicated for these patients because it affects not only depression, but also norepinephrine. So it can actually help for pain relief. But the big one is going to be using gabapentin. That's kind of mainstay treatment for patients who have post-herpetic neuralgia or pain associated with the zosters or shingles. When it comes to eye-wise, where we tend to hesitate to use steroids with patients with simplex, you absolutely can use them with zoster, right? So it's not going to cause the lesion to spread or anything. It's actually indicated for any ocular involvement that steroids need to be used for them. Now, so when I talked about head study earlier, there's actually now a Z study, and this is the zoster eye disease study. And what they were looking for, and I don't know if you've seen this in your patients, but I've certainly seen it, patients who have come in with, ophthalmic, so zoster's ophthalmicus, that we do the oral treatment and then it doesn't kind of resolve, or it resolves and it kind of flares back up again. And we really couldn't really figure this out. Why? It used to be that we treated them, they got better, and then that was it. But now there's these kind of smoldering infections, there's chance for recurrences, and it was kind of weird. So they did this study where they were getting 12 months of low dose valacyclovir, so 1 gram a day for 12 months. And they looked at the delays time to development of a new or worsening or specific I to Z manifestation of zoster. So in other words, did it continue? Did it recur? What happened with that? In addition to that, after the 12 months treatment, they did follow up for another 6 months to 18 months, and they looked at whether or not there was a persistent treatment effect after the 12 months, and they also looked at pain as well. And what they found is that this 1 gram dose for the following year reduced the chance of new or worsening keratitis or iritis in immunocompetent patients, non-pregnant adults with good renal function. So there was actually a benefit of decreasing this chance for smoldering infections or recurrent ones in patients who took it for 12 months. They even saw a better effect at 18 months. Even after they stopped the treatment, there was actually better evidence showing at 18 months that it was actually more effective than not doing anything at all. In addition to that, they found there was actually a reduction in pain for patients as well. So significant decreased pain duration at 18 months. I don't know if they saw it at 12 months, but they did see it at 18 months. So now the new recommendation for patients is if they have any ocular involvement, so they have any involvement of the nose, they have an iritis or a keratitis, the indication for them is to do 1 gram once a day for a year. And the hope is that they kind of don't get these recurrent lesions or the recurrent iritises or keratitises, and that there's hopeful potential reduction in pain for them as well. Last thing I'll talk to you about is the Shingrix vaccine. This was approved in 2017. It replaced Zostavax. You no longer can get Zostavax. And why it replaced Zostavax is because it's a far superior vaccine. In patients from 50 to 69 years of age, it prevents the development of zoster shingles by 97%. Over the age of 70, it's 91% effective. But what's most effective and what's most kind of important for this one is it prevents postoperative neuralgia in 91% of patients. And this is the huge thing about, I mean, it's not fun to go through zosters or shingles, but what you don't want is that pain. When I had mine, it felt like someone was taking an ice pick and just stabbing me all the time. Again, T3, T4, anything that touched my skin was excruciating. So I actually slept on my bathroom floor because it's the only place I could feel I could get comfortable. You don't want that forever. So that's the big plus to this one is the 91% prevention of postoperative neuralgia. It's indicated for patients 50 and above. You really can't get it much below 50 unless there's a very specific reason why it's prescribed. Mainly because of the fact that the chance for postoperative neuralgia, when you remember that slide earlier, dramatically increases as we get older. If you got it when you're 30 years old, we don't know if it's going to potentially wear off by the time that really huge chance for postoperative neuralgia develops. So it's only indicated for patients 50 and above. It's a set of 2 injections. You get an injection once, and then typically a month to 2 months after you get the second injection. I didn't have any side effects to my first one, but when I did the second one, I felt kind of crappy for about a day, and then